morning. Ron are kind of working out our system to get me into the classroom. So when he has an exam in the morning, then I'm kind of at the mercy of him. So I may try to catch him before. So thank you for your patience this morning. How's the week going? So far, so good? Did you enjoy having last week a little bit? A little bit of a break, hopefully, to kind of get ready to go again. All right. So today we are going to change kind of focus from, we've been talking a lot about lifestyle habits, some of the things we know that research supports related to health and wellness. Well, last time we met, we interviewed a patient looking at kind of that whole family situation. So now we're kind of taking it forward and looking now at lifespan. So we're going to talk this week about children. Next week we're going to talk about teenagers, trying to figure out why they act, how they do, and how does that affect how we take care of them. And then the last time that we meet in class will be over healthy women and men. We'll talk about screening, some of the common illnesses, conditions, some of the things that we know kind of happen to us across our lifespan. We'll compare men and women, all right? And we'll also review for the second exam, and we'll review for the final that day. Because then the following week, we don't meet, we can meet for the test on the 30th. Then the following week is dead week, which I'm not sure nursing really knows what dead week means because we still do a lot. Many of you still have clinicals, especially if you're the Thursday group that misses out because of Turkey Day. But anyway, so you have some classes that week, some activities that week, but we don't meet. And then the following week we meet for finals, which our final is scheduled for Wednesday. I believe it's, the 16th? Is that the 16th? And so all sections will be taking the test at the same time, so there'll be a lot of you here, but we'll get more information as that gets closer. So really this week and the next 2 weeks, and that last week we meet, we do review for the exam 2 and review for the final. So that's going to be important that we look at that and go from there. Okay? So that's kind of how things play out. So now we really kind of switch gears talking about children. Many of you have already seen a lot of information from Healthy People as you work on your projects and from the emails I've been getting, letting me know that you're trying to find information on your topic, your target group, and just a reminder, you can use Healthy People for your target group in addition to your topic. Because some of you are saying it's hard to find Healthy People related to whatever it is you're doing your topic on. But you can also go back and look at what do they say for children, what do they say for adolescents and adults, and that might help direct you. Remember, it can be more general as well. But it's really pretty clear for children that we really talk more about specific things related to kids. That's one thing that Healthy People really, really gets, is that we've got to start early and move forward. We've got to look at obesity from the beginning and not just talk about it in middle and later adult. So we really know that we want to reduce deaths among children. What do you think the number one cause of death among children is over 1 year? You can guess without even doing anything in this class. What is it? No?
Accidents.
Accidents, right? Because that's all we do as nurses is we do all this teaching. Below 1 year, we actually tend to see more congenital anomalies. We tend to see more illnesses as well. But when we go over 1 year, when they're mobile and they're up and moving, and they're going to be in your exam room and you're going to be there for their immunizations, and all of a sudden they're going to pull something off the wall, that's the time that we really have to focus on that. What kind of accidents is going to vary a lot as to their age. So we really want to do a lot of teaching related to how we can reduce deaths among children, okay? Reducing low birth weight, preterm births. We have lots and lots of initiatives that are out there that help us to identify kids that are going to be more at risk for low birth weight, as well as identification of preterm birth early on. Prenatal care. We know that if we lived in an ideal world, and everybody would come in and do their preconception counseling and tell us they wanted to get pregnant, and then they'd come in and they would be seen by us, from the very beginning of their pregnancy, we know we probably could have better outcomes. But that's not the world we live in, right? They show up 6 months pregnant, sometimes in the ER with stomach pains, and they have a baby, right? So those are the kind of things that we want to try to get education out about. We also know, and this is a big one, that alcohol, cigarettes, and drugs, the earlier they're started, the more significant they are into their teen and adult years, especially smoking. Many students that come to me and are like, I've been trying to quit smoking forever, and I've tried all these things, and I've had all these resources. And you ask people, when did you start smoking? Many times it's in your teenage years. And so those are those habits that if we can help them find other places to do things, that hopefully that will help. Breastfeeding. We always have known breastfeeding was good and it had benefits, but it's not until recently, I'd say the last 5 to 7 years, that we actually have research that says it actually acts as a medicine, especially for preterm babies. I remember, teaching how breastfeeding was a good way to feed your baby. Not that formula is not. We have done wonderful, wonderful things to enhance formula. We have lots and lots better nutrients in them, so that's better. But when we look at breastfeeding, the docs would always say, breastfeeding is good, and that's kind of how they said. Well, it wasn't until we did studies on preterm babies in the NICU that we actually found that breastfeeding, especially for high-risk babies, has the same medicinal purposes as some medications, some of the therapies that we do for them. And so when we look at that and how important that is, now you see doctors telling their preterm moms that are in there with their babies coming back and forth that we really, really strongly recommend that you breastfeed. That's really what we want you to do. And they write an order for that. They can't breastfeed, they can't pump. We also have a mother's milk bank here in North Tarrant County. So we're not just saying anymore that breastfeeding is good, we're saying it's the preferred if we can at all do that, especially for high-risk babies. Reducing neural tube defects, those are the spina bifida, those are the holes in the spinal column that we try to avoid or reduce the severity of those. And so one of the things that's been key in that is folic acid. We know folic acid helps prevent some cancers, it helps prevent some heart disease, overall well-being, but it was really, really related mostly to neural tube defects. We also know that the earlier we screen for developmental delays, that's things like Head Start, some of the government-funded programs you see in the school systems, those are really important as well. So getting kids plugged into those early on is going to be really key as well. So those are just some of the things that Healthy People really said we need to spend time on and do that. And most of you are kind of shaking your heads like you've heard about those things, so that's probably really good. So let's start with babies. That's probably a good place to start, don't you think? When we talk about newborn and infant, many times we've used the terms, the same. We kind of say that they're synonymous, but they're really not. The newborn is the first 28 days alive, kind of that first month. And then the infant is from 1 month to 1 year. And we know there's lots and lots of things that change and happen over that period of time. Really during that first period of time for the infant, they're really learning just to survive. And so are the parents, right? So they're learning kind of that trust versus mistrust. So they cry a certain way, and you meet their needs. You do something, they do something else, and they find that, okay, that's kind of that cause and effect. So they're experimenting, just like many new parents are experimenting in how to do that. So it doesn't mean that if you don't answer your baby's one cry, that they're going to end up being, a psychotic person, all right? But what we're trying to teach parents is that they need to learn their baby's behaviors, listen to them, and many times they can tell us more than we can what their cries and their signals mean. They're also beginning to develop a little bit later on during infancy that object permanence, where they know that even though something was there, it's still there. And so sometimes you start to see that, like if they drop their little cuddly animal or something from their crib. As they get a few months down the road, they start to realize it's still down there, and that's why they're sitting there pulling on their crib, is because they want you to get it. We know that their birth weight should double by 6 months and triple by a year. And that's a really, really good rule to help you when you're working with kids. Your senior 1 semester, you're going to be doing screenings, you're going to be doing height and weight, you're going to be doing a lot of things. And really what your goal there is to learn what's normal development. So if you can say a kid comes in, they're 6 pounds when they're born, and by a year they're like 21 pounds or close to that, they're close to what they need to be. So that's kind of an eyeball on kind of where their birth weight should be and how their weight should triple over that year. They kind of go from head to toe in development, and so that's one of the things that we kind of look at. So we expect their head to develop a little bit sooner. We also know that their head's a little bit bigger than the rest of their body, which makes a difference when they're a toddler and they're running around and they look at the toilet and they want to pull their toy out of the toilet and their head goes down and they can't get back up because their head weighs more. So there's some safety issues that go with that too, but that's all a part of their growth and development, and things start to eventually level off. We also know they move from fine to gross motor skills, and so when I talk about that, I'm not real concerned about you knowing all the months for everything that happens. A lot of times students ask me, do we have to know exactly when the landmarks occur? What I want you to do is to be able to be in a clinic room and to be able to look at a 1-year-old and to be able to say to me, yeah, they're on target, they're doing what they need to do, or do we need to raise a red flag? What NCLEX and HESI test you on is basically things like you have a hospitalized child, let's say Johnny has been hospitalized with respiratory distress syndrome, or he's in there with some type of upper respiratory infection, mom and dad are in the room, and he's 1.5 years old and he's doing this. Is that appropriate for his age? Okay, we know illness changes things, but we also want you to have some kind of a general idea on what's normal for growth and development. So as you study this and look at this, that's kind of what I would do. I'm not concerned about you knowing every month what happens to them, but by 6 months, by 8 months, by a year, what should a 1-year-old, a 2-year-old be doing? And I'll give you some tips on that in a little bit. But so the fine pincer grasp, which is what we're trying to develop, really goes from them just kind of doing a blind grasp to eventually, by 2 years, they're actually able to use their wrist action and actually able to put like the little squares or the little pegs or whatever they're trying to do into the right little slot. Their gross motor skills, they really start with sitting up, which because their head's heavy, what do? They have to lean over and kind of lean over on their arms to do that. But then we get to where they're about 2 years old and they're starting to be able to do more running. By 1 year, we hope that they're starting to make attempts to walk. So you can kind of see where the fine and the gross motor skills kind of work together. Things that influence how we develop. Boy, doesn't that make a difference? If any of you had one child and you watched them develop and then you watched the second and the third one, the brothers and sisters probably helped that first one, or they were doing such really fun things that little one's like, I'm not missing out, and maybe they started crawling earlier or they started walking earlier. They did those kinds of things as well. So you really do see a difference in their sibling and where they fall. How many of you are older children? You're the oldest one in the group. So tell me, what's it like to be the oldest sibling? All right, so the only children, we'll talk about those in a minute, they're kind of everything, aren't they? All right, so those of you that have brothers and sisters and you're the oldest, tell me what that's like. What was expected of you? What did you do? How did you act? Yes? Yeah, or just... Those of you that are the oldest, do you remember? Are you awake? You're the role model. You're the leader. All right? You were probably always supposed to set the good example. You were kind of the experiment for your parents, right? They kind of tried everything on you to see what worked and what didn't. And then you probably saw as they got to your younger siblings, they kind of changed the rules a little bit. You maybe felt like they kind of loosened up a little bit. You're like, I never had to do that. How many of you are the baby of the family? Do you like being the baby of the family?
Yes.
Do you feel like you're always the baby of the family? You'll always be the baby of the family, right? I have not talked to very many that were not the youngest that didn't like being the youngest. So tell me what it's like to be the youngest.
Fantastic.
Fantastic. And why is it so awesome?
Parents loosened up.
Yeah. By the time they get to you, they're like, forget it.
They figured out it.
They figured out how to do things. All right, so they're more reasonable. Did you still have pictures of you, baby books of you, or did they just have them of the others and not of you? Okay, so you don't have as many. What else? Youngest. Where are you at? All the youngest. Yes?
You get to see like what your elder sibling did and that you should avoid doing when you get
Yeah, you learn a lot, don't you, by watching them. That's very true, yes. Did they kind of coach you and help you, though, too? Do you feel like they helped you at all or not? No? On your own? Okay, and then those of you that are the middle children. All right, what's that like?
You always get left out.
You always get left out, all right? Does it make a difference in how much older and how much younger your siblings are? or not? Because I know some people tell me they feel like they're the only child kind of because they're kind of on their own because maybe they're
In my experience, it doesn't really matter. Like the oldest gets a lot of attention because she's the first one experiencing things.
okay.
Like the first one.
So you watch and learn?
When the younger one, well, everybody spoils the younger one. She's
Yeah.
a baby. Even I spoil my youngest. So.
So you're kind of like, I'm here. I'm still here. I know I'm married to one of those. My husband had two sisters, one older, one younger. He was in the middle. He's used to sharing the bathroom. He's used to doing whatever ladies say. It's been wonderful. It's been wonderful for me. But I found that the middle children are peacemakers. They kind of want things to kind of go okay, and they're kind of used to like, okay, he's upset, she's upset. Okay, we're okay, we're good, we're good. You know, they kind of try to blend in. I don't know if you feel that way, but anyway. How many of you that are married or have a boyfriend or whatever the arrangement is find that you have a partner from a different sibling rank, like so positions? How does that work? Does that work out good?
I've been married for 26 years.
Okay, so are you the oldest?
I'm the oldest and he's the baby.
He's the baby. All right. So does he kind of let you do? Does that work? Do you kind of have your system, obviously, or?
Yeah, it does work because he's also a peacemaker, actually. So it's, I care about 98% of the things in this world and he doesn't.
Okay.
So as long as it doesn't go into his 2%,
Yeah, we're good.
I can do whatever I want.
But wait, that's really good for him though, because he knows you've got it all taken care of. That's kind of good too. So yeah, it does make a difference, though, I think, a lot. How many of you are from families of 3 siblings or more? All right. How many of you are from smaller families that maybe have only 1 or 2 siblings? All right. Okay. How many of you are from families where you were the only child? Yes, I love that. All right. So tell me about being an only child. So tell me about that. How does that work?
It's pretty awesome.
And you say that because?
I've been, honestly, it's awesome. That's one way to describe it. The other way to describe it is just being blessed. No, I'm being serious.
So are only kids always spoiled, do you think?
Well, I've worked since I was 16, so spoiled is kind of a subjective term.
Okay.
But, and I worked through college and working now.
Was that your choice?
Yeah, that's my choice.
Okay. So you're very motivated.
So, but in the same regard, that hey, I'll graduate whenever I graduate. I'll graduate with no debt. Graduated with my other degree, no debt.
Okay. So that was important to you.
So, spoiled is some people can say spoiled,
Yeah.
but I've done a lot to help myself in that regard too. But you get a lot of attention.
You're with adults a lot.
Yeah, I got really epic birthday parties growing up.
Right.
But other than that.
Wonderful. How about the rest of you? Yes.
There's also a lot of pressure because, like, you're the only shot they've
Yeah.
got at
Yeah.
a time.
My son was so happy when we got a dog because at least now when there's something broke, it's not completely my fault. I can blame it on Duke. I'm good with that. So you're true. There is a lot of pressure and a lot of expectations. It's a one and done plan. I mean, this is it. You're either going to really mess them up or they're really going to turn out okay. And so I'm sure there's a lot of pressure on kids too to do. And you're around adults a lot, which makes a difference too in how you grow and develop. Anybody else? Yes.
I think it feels good to know you're the only one who inherits everything.
It feels good what?
The only one that inherits everything.
Okay. Okay. That's a great question. I love that. You get it all. That's right. That's right. There's nobody to have to share with. Yes.
You're the only one who has to take care of your parents, though, too.
That's true. There's a lot of pressure. There is. Yep. You don't have that sibling, that daughter, that sister, that brother that you can kind of talk about things. So I think that pressure, that leader, that kind of thing kind of stays there as well. All right. So things that affect our development, absolutely. Where we fall in our family, our size of our family, our gender makes a huge difference as well. How we're raised, our ethnicity, our environment, how we're promoted, that makes a difference too. If it's expected that we, do things, that's going to make us probably rise to the occasion a little bit more. And in our personality, are we more laid back? Are we more self-directed? Do we like to take charge? Those are all going to make a difference too. So then when we talk about an infant's development, there's just some things I want to do to help you, because when you look at those charts and you're like, do I have to memorize all these charts? Well, no, you've all been in a child psych or a child development class. So you've had to kind of look at how children grow. But again, what I want you to do is kind of take that nurse face that you've worked so hard this semester to have in the hospital, and to kind of start to think about when I'm in a room and I'm assessing a baby or I'm assessing a child, what should they be doing at the age they are? So some things to kind of help you with that. 0 to 3 months, we kind of call that recliner phase, and the big thing for that is because their head does not have the strength and developmentally the support to be able to hold it up, so their head's going to kind of lag behind. So if you pick them up, you're going to pick up their arms and they're going to kind of come forward, but their head's going to be behind as well. By about 2 months, they're starting to be able to lift their head and the chest, all right? And you'll hear the parents, they're like, my child is so strong. That's not the time to tell them. Every other child can do that too, all right? So that's when you say, yes, your child is very strong, and that's really important. They learn that. By about 3 to 6 months, they start rolling over. They kind of go from that, being able to lift themselves up, to being able to sit. Now, you see here, Andrew's kind of rested on his hands, and that's important because his head is really heavy. And you can always tell that a child's a little bit older, closer to 5 to 6 months, when they're able to sit more erect, and you'll see that as well. By about 6 months, they can start to lean a little bit more forward. They can start to get rid of their hands a little bit. But again, that neck and that head is developing more, so they're able to have a little bit more strength to do that as well. What else are they starting to do by about 6 months to 8 months? They're starting to crawl, aren't they? So they're going to be on the move. So you put them one place, and they're going to get to another place, aren't they? All right? They want to be moving, so that's why those bouncers, those little toys that will keep them kind of active and moving, but keep them in one place and contained, that's really important. Usually by about 8 to 9 months, they are starting to crawl, and they see everything. They're looking at the world from a whole new view. If you have never done that, I hadn't really thought about that until I was a mom. I got down on the floor and I'm like, oh my gosh, there's a lot of stuff down here and there's a lot of dirt down here too. And so, you start seeing, because that's the child's new environment. And so they're like, oh, this looks neat and this looks neat. And they start putting everything in their mouth. So you kind of want to look at that as well as they start to work on that. And then they get kind of closer to about 9 to 12 months where they kind of become that cruiser or that walker, where they start to make attempts to walking. Now, what we want to get away from is saying that everybody needs to walk by 12 months old, okay? Parents do that for us, all right? If you haven't been in that parent network game, parents are very good at comparing, all right? And what they do is they say things like, well, my child was walking by 10 months old, and you go home and you go through the internet and you look at all the books and you're like, oh, I'm a horrible mom because my child's not walking yet. Your child probably won't walk or make attempts to walk till 10 to 12 months, and that's okay. So what we're looking at here is, are they making attempts to walk? Not that they can physically walk. What does furniture cruising mean? They kind of hold on to this, and then they kind of run over here as much as they can, or they fall, and then they pick themselves up with something. So they may go from the coffee table to the end table, they may grab something. So they're trying to get around, but they're not steady enough to do it on their own. Yes?
Just a quick real-life example. Put that in your head. My son didn't walk until he was 15 months old because he didn't have to. He would pick up his little fat arms, and someone would pick him up and take him where he wanted to go, including his sister, who's only 2.5 years older than him. So he didn't bother.
There was no reason to.
There was no reason.
He got where he needed to be. And so that's an excellent example of an interview question, or looking at what does their family look like. If they've got somebody doing that for them all the time, that's going to make a huge difference. They're also going to cling to mom, so even though they're trying to get on their way, they're going to look back and make sure they can see where you are, okay? Because they're really wanting to make sure, and they're still trying to figure out, you're coming back, right? They're still trying to figure all that out, so that's all new for them as well. The nice part about this phase is if you get them at a happy place for a little bit, they start to entertain themselves a little bit. Now, that doesn't mean you can walk away and leave them alone for very long. You always want to have your eyes on them because they're going to change in a second. But they still are starting to entertain themselves a little bit, and those of you that have had 4 to 6 months old know that you have to kind of be there with them the whole time. I have just a quick little clip that's done by a med student on infant milestones. It's kind of a nice little way just to kind of help you generally look at it. She talks really, really fast, and she talks about med students and exams and things like that, but it's very applicable for nursing. So I'm going to go ahead and let you listen to that real quick.
Tell me the first statement that learning to develop virtual milestones was one of the most challenging. And by challenging, I mean frustrating things I've learned in medical school. This video is for those of you who are like me. No children of my own, didn't grow up with younger cousins, and was too young to really remember when my little sister passed these milestones.
We'll find out where it went.
The milestone tables out there are new. By looking at them, there appears to be no reason as to why milestones happen when they do. My job here, but rather it's to help you come up with an approach for memorizing milestones. I'll also try to point out, in my opinion, what is the bare minimum of what you need to know to pass the exam and stay afloat on PDF workshops. Again, for the purists out there who believe in and can memorize long tables of information, this video is not for the rest of you. Let's begin. The best way to think about the milestones is first to eliminate all the extraneous time periods that you find in books and tables. This means pay attention to the major age groups of 1 month, 6 months, 9 months, 12 months, and 24 months to be precise. We can also throw in 3 and 4 years to be fancy. Now let's start from the 1 month to the 1 year time. After 1 year, the goal is to have a toddler who can walk by him herself, gross motor skills, use a 2-finger pincer grasp to pick up objects, fine motor skills, say mama, dada, language, and imitate a parent, social cognitive. If you choose to remember one set of things, I would remember just these 4 things. On the flip side to the 1-year-old is the 1 month toddler who can barely do any of this. Imagine a 1-month-old can only lift their head when thrown, track things with their eyes, coo, and recognize their parents. One caveat, which I hope will not throw you off too much, is that while walking is strictly a 1-year thing, the 1-year-old who can't walk is not necessarily delayed. What you will be given on a test, however, is the 1-year-old who can only sit up, i.e. who hasn't even passed the 9-month milestone that you would call delayed. Now, if you understand this, it's easy to remember the stuff that's key, or at least it's easier to guess. 6 months is the halfway point between 1 month and 1 year. It's also the halfway point between lying down and standing unassisted, which you might guess is sitting. It's also the halfway point between being able to use 2 fingers to grasp an object and not any fingers at all, which we will inventively call the raking grasp, or using 1 hand to move an object. The 6-month-olds are 1 step up from cooing, but can't say mama, which means that they can just babble. And finally, not only do they recognize parents, they've also learned to recognize strangers, i.e. have stranger anxiety, which is one of the big cognitive factors. Now for the 9-month-olds. Going with our approach, 9 months is halfway between 6 months and 1 year. The midway point between sitting and standing is being able to stand with assistance. For fine motor, 9-month-olds can use 3 fingers. Again, not raking with 4 fingers, but not the fancy 2-finger grasp. Language doesn't follow exactly the rule per se, as the early brain can say mama, dada, but being able to say this or not say this doesn't mean anything at 9 months. This also means that language at this age is usually not tested on kids. And finally, the 9-month-old can not only recognize, but they can interact. They can wave bye-bye and play pat a cake, which you could perhaps think of as less complex than imitating a parent. Again, this is not a ton to memorize, but knowing just this will get you really far. In my opinion, the 15-month and 18-month marks are pretty low yield, but you can still use the same strategy. If you remember the 1-year and 2-year marks, then you can figure out everything that should fall into. Exams usually don't test these months, and on your rotation, you can ask the parents what new motor, language, or social skills the child has developed since 1 year. and using the one-year milestones to memorize to help prompt them. Then you can go to your attending and tell them whether they are or are not meeting the milestones with just the 1 year and 2 year information. The next big category is the 2, 3, and 4 years. These tend to be easier because the numbers correlate well. 2 years is the year of twos. 2-year-olds can walk with me 2 steps, i.e. 5 steps, say 2 word phrases, and follow 2 step commands. Motor does fall out of favor with 2-year-olds because they can stack 6 cues instead of just 2. But basically, think of them as just being able to stack a bunch of things. 3 years is the year of practical 3-word sentences. And they can also brush teeth. 3-year-olds can copy a circle, which kind of throws everyone off, and I'm afraid this might need to be memorized. However, in reality, i.e. in the clinic, many of the 3-year-olds were drawing much more complex things than just circles. One nice pro, which I did learn from my preceptor, is that for fine motor skills, kids should be able to roughly draw a person with at least as many parts as their age. So a 3-year-old can draw an outline of a face with eyes and a mouth. 4-year-olds will be able to add a nose to this mix. And finally, the 4-year-old can hop, copy and cross, and play with other kids. So this is my attempt at a picture mnemonic. You can picture the 4-year-old whose legs look like a 4, hopping along boxes with crosses next to other kids. Again, this is a very bare-bones approach to learning these milestones, but hopefully this made a bearable table into something slightly more digestible. For those who like to memorize or are interested in keys, at least now you have a good framework for memorizing. Now for the take-home points. These are the bare minimums to know. 6 months, sit up, raking grass, stranger anxiety, bowing. 9 months, between the 6-month and 1 year mark. They can walk with assistance, 3-fingered grasp, way bye-bye, had a cake, and possibly say mom and dad. At 1 year, now they can walk, use a 2-finger grasp, say mom and dad, and imitate a parent. 2 years, 2-word phrases, 2 steps, 2-step commands, and stacking cues. 3 years, 3-word sentences, ride the tricycle, brush his teeth, and circle drawing. Sorry, you have to memorize that. And finally, 4 years, they can hop, copy across, and play with others. Just try to remember the silly picture mnemonic I shared. Thank you.
Okay, so that's just kind of a quick way to help you kind of think about it. If that helps you, great. If it doesn't, then you can go back to the chart. So you do what works for you. In all of this, again, really looking at just some general things for kids, all right? Not concerned about you being able to tell me every month and every landmark. But if you have a child that's in the clinic and they're 3 months and they're 6 months and they're 9 months and they're 12 months, what should you be looking for? What should they do? We're going to talk about growth grids in a little bit. The same kind of happens with that. Just because a child does not fall in the growth grid that you want them to be or where you expect them to be doesn't mean that there's a problem. But we're trying to kind of think about what are some anticipation of some delays that might happen to them. All right, well, some of the really cool things that babies come with are some reflexes. And when you're in your senior 1 semester, you'll get to actually practice these and do these on a baby. But right now, I want you to just think about these as things that a baby comes with, things that parents are going to ooh and ah over, because it does help their attachment, their bonding to develop. They have that little plantar grasp, which they can curl the little fingers around your finger, or the little toes around your finger. The palmar grasp, they can curl their little fingers around, so you can see that as well. The Babinski, you've learned about Babinski in assessment, and you know that on an adult, we don't want to have a positive Babinski, but we do on a baby because they have an immature central nervous system, so we expect that to be there. So when you stroke the soles of their little feet, their little toes are going to curl out. We know babies are known for sucking. They also are known for rooting. They're going to turn to the stimulus that they think is going to let them suck. The finger, mom's nipple, a bottle nipple, whatever that is. The trunk incurvation, if you stroke a side of their spine, they're going to wiggle their little hips that way. And that's just a reflex that they happen, so they kind of do like a little hula wiggle there. Tonic neck actually is something that we can see when they turn their head one way, and most of the time it's when they're sleeping, they're resting, they're quiet. When they're screaming, it doesn't work as well. If you turn them over, you're going to see them do kind of like a fencer position. You can see their little legs kind of mimic, and then if they go to the other side as well. Tongue extrusion reflex. This little girl is probably retired, living on some island somewhere, just enjoying her life, because she's probably in every tongue extrusion reflex picture I've ever seen. She's a little bit older, but she has a really good tongue extrusion reflex. And one of the things I want you to remember about that is babies are born with a reflex to stick their tongue out. Now that's different from tongue thrust, which is something that becomes a problem as they get older, and we have to retrain their tongue to go back, and there's a reason for that, and that's not what I'm talking about. But this is a reflex where they actually are going to push their tongue forward instead of back. So what we have to do when we teach them to feed them is we have to help them to put that nipple, whatever it is that we're trying to get them to feed from, to help bring that tongue back. And usually that's a very easy thing for them to do, harder for some than others, but it's a reflex that they're born with. That usually disappears by about 5 to 6 months, which what happens with feeding at 5 to 6 months? We usually start having them take in solid food. So as that tongue extrusion reflex diminishes, that's usually where we kind of do that. And there's other reasons that happens too, but that's one of those reasons. Language development, a whole nother world. Have you ever been with parents that have a baby and you're like, I have no idea what that child is saying, and the parents are talking to them like they're having like this conversation that's going on. That's because they've listened to them. So a lot of times they're going to develop that expressive language first, which is kind of where they're just kind of trying to let you know what's going on. The receptive, they're starting to understand. You start to see that with children. They don't like always your response, but they will let you know that they don't like that they're done eating and they have to lay down. And so they want to be with you, so they understand what you're telling them. And body language, another way. You see that with them so many times. They can also read our body language very quickly, too. So they kind of start with that pre-verbal, where they actually do the crying and the smiling. Remember, we say it's so cute, you know, they're crying, or we know that that crying means this, or they're smiling. They start to make some repetitive sounds about 3 to 4 months to kind of go into that babbling. And then, of course, they say the famous mama or ma or dad or some word by about 7 to 8 months. We usually say that's kind of where that first words come in. But they also know to make specific sounds for words they can't enunciate. And so that's where you hear parents all the time, oh, that means blankie, or that means this, or whatever. And so they have learned that. And then usually they'll start to do more high-quality words that they'll kind of put together that are easier to understand, usually as they get closer to a year. So what do babies do really well? Well, they play really well, don't they? And play is their work. All right? Wouldn't that be nice if we could just play all day, right? We think that would be fun. But for them, it's just as hard to do that as for you guys to go to school. I know it doesn't seem right, but that's the way it works. But that play helps them to discover, it helps them to learn to express themselves. But a bigger issue is it helps them to develop that interaction with their caregiver. And so whatever it is, my child loved water, all right, from an early age. Some children, you put them in water and they scream. That's not going to be therapeutic for them, all right? But you want to find something that they enjoy and that will help them to connect with their support people. Infant massage, another thing that's really, really popular and has lots and lots of key benefits to helping to relax, helping children to center, helping them to just feel connected to whoever's providing that. I know a lot of moms I've talked to when their children go to, they're in early childhood or they're in like school age periods, they'll still want their back rubbed or still want their thighs rubbed or whatever mom or dad did that helped to relax them when they were young. So those are all positive things we can do to help with connection, relaxation, and all of that. Babies are very social. They mimic what they see. May not always be what you want them to do, but they're going to do what they see. And they let us know very early on when they're done. And so a lot of times we get really frustrated because they get really cranky, they turn away, they're not having our attention. But their attention spans are very small. That's just part of that development. But also they get overstimulated. So when you bring them in a room and they have mom and dad and grandpa and grandma and the cousins and it's turkey day and everything's going on and they're not happy and everybody's like, oh, you never asked like this before. It's because he doesn't have 15 people around oohing and ahhing over him. So there's a lot of that we can also help them to do. They also, though, want to make sure they know how to get our attention. And so if what they have done isn't working they'll switch it to do different things because they want to do something that's going to hopefully get our attention. Some of you may know about Terry Brazelton. He has been a very, very well-known researcher. He's worked with children all through his life, his own children, his grandchildren, in addition to lots of other children. But he has done a lot with what we call touch points model, and I was fortunate enough to work with him when he was here for some time doing his touch points training here at downtown Harrison, Fort Worth. And one of the things that his whole training does is helps us learn how to connect parents. And his whole thinking is that if we can connect parents from an early age, they can connect with their children, they can learn what's normal. It's going to help them get through those teen years and some of the more challenging times that they go through as well. He's a real firm believer in on-face, that face-to-face contact. He wants nurses to show parents what kids can do, some of those reflexes, showing them, how strong they are, showing them that one of the things he always uses as an example is like when the mom listening to the baby or the baby's listening to her and they're trying to connect, he'll show the mom that, now see when you talk, the baby turns towards your face, because the baby knows your voice. And mom's like, really? She hasn't thought about that. And so those are the kind of simple things. Well, it's kind of neat. Brazelton's a neat man, and he's got a lot of information that is out there that's great. But one of the things that's really neat is he's also now taking the touch points model and using it in ICUs and in ER settings because it's helping parents and patients to connect as well. So it's not just being used for children and babies and that kind of thing anymore. We also know that infants start to develop that separation anxiety where they don't really always know you're going to return in the time frame that you're going to return. And so when you leave, they start to get more upset. And that's very common to happen around 6 months for them, and that's going to get better as time goes on. But that's important for parents to understand that that's a part of their normal development. We know babies sleep somewhere between about 10 to 16 hours. We definitely know parents don't get to sleep that much. And we also know that their maturity is going to make a difference in how they sleep, how long they sleep, when they sleep. We know they get their nights and days mixed up. And so it takes some time for all of that to get worked out. But that sleep is so important for their growth and development, too. I know the first thing you thought of this morning when you got out of bed was baby poop, so I want to make sure I talk about that for you. We talked about adult poop, we have to talk about baby poop. So the type of poop that the baby has looks different depending upon how they're feeding, if they're breastfeeding or bottle feeding. I tell you that because a lot of times parents are going to ask you and they're going to describe this poop to you and you're going to be like, I have no idea if that's normal or not. And so one of the things I want you to look at is what poop looks like for a breastfed baby. Obviously, the first poop that comes out is that meconium, and it's really black and sticky and tarry, and it's kind of hard to get off. But that's got the amniotic fluid and some of the hair that was inside and everything from the amniotic sac. So all of that has to come out. Okay, so once that comes out, then everything starts to get going. And usually for a breastfed baby, the poop is going to be more of a green color by about day 3 or 4 and about yellow by day 5. Now, most moms are going to be in the hospital a couple days if they have a vaginal delivery. So you're probably not going to see it change like that until they call you and they tell you. And they may call you and they may say to you, my baby's poop is yellow, it's got little seeds in it. You're thinking, well, that sounds really gross. And it is. Kind of looks funny, but it's normal, and that's what I want you to understand. And a lot of that is just from the breast milk going through. Breast milk kind of has a laxative effect. If you've had a baby, if you've fed a baby, you know what I'm talking about. They feed, and then there's this dynamic explosion that happens within your baby where the breast milk moves through the GI system, and all of a sudden there's this huge explosion at the other end, which tells you that they got rid of it all, okay? And it's just more of a laxative, it's more thin, and that's just what happened. Now, they absorb a lot of what they need, but it's not going to bulk up and it's not going to stay in the GI system very long, and so that's kind of what it can look like. If they would have bleeding or anything like that with it, they would need to let someone know. It doesn't mean that there's a problem, but they do need to let us know as well. Now, formula is much different. Formula needs to have a little time to bulk up and to be absorbed, so it's going to take a little bit longer to move through the GI system. It's going to be a little bit more solid when it does move through, a little darker color, and it does have an odor. You can, if you're trying to convince a mom to breastfeed, you might want to tell her, well, if you have a breastfed baby, the poop's not going to smell that much. So just another thing you can help her to understand. But that's very different from what it could look like. So just know that so that you know there's a difference. Babies can have anywhere from 6 to 10 diapers per day. They can have more than that. So just think about every time they're feeding, they're going to need to have a wet and dirty diaper. That's really basically what's happening with them until after that first couple weeks when things start to change a little bit as well. So where do we begin with doing our assessment and our screening for a newborn? Well, within the first 72 hours, which is, of course, when they're usually in the hospital, birthing center, or even if they're a home delivery, we're looking at that there. We really want to check 4 key areas. We want to do a quick head-to-toe assessment so we make sure everything looks normal. We want to make sure we check their eyes. We want to make sure we check their cardiac system, so we're going to listen to heart rate. We want to make sure we know what their heart rate is, and we also want to listen for murmurs. And then we also want to make sure that they don't have any hip dislocation. That can also be from their shoulders or their clavicles as well, from birth trauma. And then we also want to check their genitals and make sure that everything looks like it's as it should be. And so those are some of the key areas that we're honing in on initially because we want to identify those early on if they're not there. When we talk about doing health promotion and some of the things we need to do for babies, we really are directing that at parents. We've got pretty smart kids out there, but we still can't do a lot of teaching with them when they're only 8 weeks old. So we really want to look at how parents, what's their environment like, what is their lifestyle like, what are they exposing the baby to, and then also be good role models. I can't tell you how many times when we're in a patient's room and I get ready to leave the room and maybe the baby was on the bed, I want to make sure that baby gets back in the crib, because even though that baby is only 2 days old and it should not roll off that bed, I'm not going to be there when the baby is 8 weeks old and it does roll off the bed. So I always think to myself that if I'm leaving the room with the baby on the bed, I'm telling the mom it's okay to do that. And that's not. And so you want to make sure that you think about falling and how to handle the baby and all of those things so that you role model good behavior for them too. By usually about 5 to 7 months, their baby teeth or their primary teeth are starting to come in. And just kind of a quick formula that helps you circle this, because it's kind of a good one to kind of know, because it seems like from the time you have a child until they're in teenage and you're doing orthodontia and everything else, they're either losing or gaining teeth, or we're pulling them, or we're doing all kinds of things to them. But their age in month minus 6 kind of will give you an idea, usually by about 6 to 7 months, about how many teeth they should start to have. Now, some babies do have, you'll see a little tooth in their mouth when they're born. Sometimes that can be just under the skin a little bit. If it's starting to erupt, sometimes they will actually pull that because they don't want the baby to choke on that. But that's different from teeth that are actually coming in a little bit later on. And then we usually say by about age 1, we want to start to introduce them to the dentist. Now, obviously, they're not going to be brushing their teeth and doing as much as we think about doing today, but there's some oral hygiene they can be doing. There's some of the little gum sponges that we can use. There's a lot of things that we can do to help increase circulation. And you also want to make sure that the breast milk, the formula, anything that's going in their mouth, and if they start solid foods, that all of that is being taken care of, because you don't want that to sit on the gums and create bacteria. There's a question. Yes?
Can you repeat that formula again, please?
Yes, it's the baby's age in months minus 6 will tell you, kind of give you an estimate of how many erupted teeth they should have. Now, again, if they're 8 months old and they don't have 2 teeth, that doesn't mean there's a problem, but it kind of helps you to know when I feel in that, that oral cavity, I might want to make sure that I'm careful, because there might be a couple teeth in there. And they will let you know if they have them most of the time by biting down. Most common cause of injury or death, accidental injury. Vehicle safety, you would think we have told everybody we could about restraining babies in car seats. And then I go through the Target or the Walmart parking lot or somewhere and I see a baby running around in the car. And I'm like, really? And so the word is out, but we don't always get people that are going to be quite as adherent with it. The front seat airbags, obviously very good for you and I, deadly for a baby, which is why the baby's supposed to be in the back seat, all right? And so that's really important as well. Those of you that have not ever put a car seat in, you need to experience that. Find someone that has a car seat to put in and try to do it. My husband and I thought, how many years of education could you need to put a car seat in a car, all right? And so here we are. I'm thinking this should be good. I'm a labor and delivery nurse. He's an engineer. We should be able to handle this. 2 hours later, we're still trying to figure out how to put this car seat in the back seat for my son. It is not an easy challenge. And I have friends that are car seat inspectors and trainers that teach classes and inspect and do some of those things at health fairs. And I thought, really? A job for that, you know? Until I heard their stories about people that drive in and they have bricks underneath the car seat to level it, or they have boards, or they've come up with this really neat device. And I don't know where they think that device is going to go if they have impact, but it's not going to be good for the baby. So there's a reason that we have all this newfangled stuff, but we really need to make sure we're using it correctly as well. So it sounds like a real easy thing to do, but it's not. Choking, falls, obviously big, so making sure that you child-proof your house. What's going to go in that baby's, air down their throat is going to be a big deal. Cooks and children's both do a lot of community service education related to helping people with choking. We used to say anything smaller than a toilet roll was going to be a problem, but now we've even found that we really need to even go smaller than that. So there's some little devices that you can sometimes get that will show you about how small something can be, because really the baby can really choke on basically anything, and so that's a problem. And as they get closer to 1 and 1.5 years, they don't want to stay stationary, right? So they want to run, and so it's really important that they don't put little carrots in their mouth and then take off and go running. So those are things that we have to watch for them and teach parents to watch for. Suffocation, hypoxia, apneic spells, another thing that we've really tried to do a lot of research on and look at. SID, sudden infant death syndrome, you've heard a lot about that, the Back to Sleep campaign. Some of you had babies and put them on your side. Some of you were told to put them on their tummies. And now we teach people to put them on their back. Now we're also starting to use what we call sleep sacks, which actually help us to control how tight we make that blanket. Anybody learn to wrap their baby like a little burrito? You were told to wrap it so tight and then watch for the baby to move, and it shouldn't be able to wiggle out. Well, now we're saying that was probably too tight. Restricted air, it caused the baby, if they got their face or anything kind of nestled in there, that it was hard for them to pull out. So what we want to do is not create that hypoxic incident for them. So we're really trying to wrap looser, keep the baby's face away from any of the animals and some of the warm blankets and all that kind of stuff as well. So the Back to Sleep campaign has helped with that significantly. The other thing we want to really be careful with there is nighttime sleeping. It's real easy for mom to do her breastfeeding at 3 in the morning, and then she's so tired she just leaves the baby in the bed, and what happens is that baby works its way down, or she rolls over on the baby and they can't breathe, and then they wake up in the morning and the baby's not breathing. So those are the kind of things that teaching-wise we can help them with. Poisoning, cuts, drowning, all things that we want to be careful of. Remember, babies can drown in a baby bath. I mean, that's really something that we want to make sure they understand. It's not just if we leave them alone in the tub or we, put them in a pool if they get a little bit older as well. Childproofing should be done each day. I used to say just childproof your house and you're good. Well, I don't know what happens, but kids go to bed and they wake up taller and smarter, and you wake up tireder and dumber, right, as parents. And so you really want to always be looking, because they're going to find things. I would have never thought my son would crawl in our cabinet, but of course he did. Nutrition for kids, and then we'll take a break. Vitamin D, obviously, is a little bit lower in breast milk. Vitamin D is added. Many times it's fortified in formula. So that's something that can be a little bit lower. So sometimes we'll check a level on mom to make sure that her vitamin D is adequate for the baby. Not something that we have to give a supplement for initially, but we may want to watch that. So that's something to ask your pediatrician about. And then iron. A lot of times babies' iron supplies become a little bit more depleted as they get closer to needing solid foods, which is one of the reasons then we try to promote more iron-rich foods as well. And that's more common in the formula-fed babies. The breastfeed babies may or may not need that. A lot of times it'll depend upon mom's iron supply too. So vitamin D and iron is something that you just want to have a baseline on. We used to say for fluoride that every baby needed a supplement until we started testing water, and we found that a lot of the water sources have an adequate amount of fluoride. So if you have well water, you live outside of the city, you're not sure of your water source, you may want to have your water tested. That's not a bad idea to do at all. But most of them have an adequate amount of fluoride where they're not going to need to have a supplement. Vitamin K, babies are born with a lack of vitamin K, which is one of the reasons they get a vitamin K injection when they're in the hospital or right after birth. They have that clean gut, which sounds really kind of cool, They don't have any bacteria really in their gut yet, which is one of the reasons we have to allow that bacteria to foster and to grow so they can actually digest foods, which is one of the reasons we wait to do solid foods till closer to 6 months. But we also want them to actually be able to synthesize the vitamin, and so we have to give them the vitamin K initially. It helps with clotting, so if they're having a circumcision or any kind of other kind of procedures early on, that's also going to be beneficial. All right, let's take a break and come back at 9:20, and we'll talk about solid foods. Oh, I know. One quick thing before you go. The honor students, you guys want to stand up, Matt and Sarah, and tell them what you got in the back of the room for them to stop and look at today?
In the back there, I have a presentation over sugar
Sugar?
in the body.
Okay. Anything you want them to do? Anything specific over there?
There is a pre-quiz. I'd like you to, if you have the
Okay.
time, go ahead and just answer the questions and just set it to the side of it.
See if you're sugar smart or not. And then he's got a poster on some information and I think some packets and stuff back there for you to look at. So, all right. And then Sarah?
And then mine's over here over fats and oils. And so kind of just have my board. I have some samples of some treats I made that are used without fats, that are made without fats. And I have also a little kind of like post kind of quiz if you want to take it after coming and visiting my station.
So they're going to go over to your booth first and get your snack, then they're going to go see how much sugar is in it. All right, so be sure to stop by their table so they've worked hard to give you some more information on nutrition.
So mine is basically and all my sugar is like extremely long. I have this sugar yeah. So I have all these and I feel like they use like they need more information on after that. But I'm gonna buy some books, but like I have some ideas but I brought pictures and
Okay, so what do you want to know?
I mean, I was talking about even I want to focus on like organic versus natural versus all the it'll be like what.
And upstairs in my office, if you want to come up, I have like some different like some pants and that kind of stuff that you might want to look at.
Okay. Okay, cool.
But if you do want to do that, come up in the class today.
Okay.
So you have it for next week. I'm only doing that only one day a week right now to start with. So if you want to get it, just it's 6
Yeah. Okay. And then
So you're focusing mostly on these layers.
yeah, like I'm gonna talk about each one of them like slowly, but I'm gonna focus on organic and natural.
Okay.
Okay. Thank you.
Just kind of what they see when they go to the
Okay. Oh yeah.
Okay, so actions, what do we need to do? What would you suggest we do? What kind of things are we doing now with your actions? Your recommendations are going to be where do we go from here? So, depending on what's going on right now and what you suggest doing, what are your recommendations? Is it follow-up, is it resources, is it the national level, local level, do you have clear guidelines? So what's your comment? Ours is so like an action, yours is like people you need to start initially if you're just starting out again. Clear guidelines, stuff like that. Recommendations would be like maybe stricter texting laws. We need stricter texting law. We need even better driver's ed classes for that information. I know all of our students have to watch that huge accident video or whatever. And I think there's texting in there, but there's some school programs that are starting to come about. I know in our community they have a program where they actually brought it over and they had like paramedics and everybody came in. It's like an accident that happened from distracted driving. And I think it's also alcohol-related DWI and that. And so they brought in, this is what we're having. That person actually died. So then they went to the school like, okay, he isn't here tomorrow. Because this is what so they played it out and it was very effective. I mean, and so I think more outreach, laws, or school guidelines. What do we do? Yeah, you might want to just show a picture, a card of something like distracted driver, maybe distracted driving happens, just stop the lane, whatever. And so, yeah. Or you can do like, are you, then this video, this presentation's for you. You can do that too. Yeah. And then on pictures, I think we'll put the URL underneath. Yes. Okay. Yeah, so that we know where it came from. And then you can get the list as well, just like you would a paper reference. Yes. So I have that like with personal information on this. Yeah. Retrieved from, just like a reference. Yeah. Somebody watches your video, they know where that clip art came from. Yeah, you got it, I think. Yeah. I just have a weird question. Okay. Okay, so like that whole thing that they use drinking water, that's better. I think that's right, and I would think like, well, you're against the water, they're going to start using tap water for days. Well, but then by then their immune system should be better, so I think you're good with that. There's some people that, why do people drink filtered water? A lot of people like filtered water, and they do that, so then they're going to do that, so that's fine, you know. But it doesn't have to be. Okay, I just was wondering, guys, I don't want to lose kids, and I was always wondering that. People always tell me like, and you know, there is nothing wrong with taking your water, just get a water sample and take it into the water supply place. That's what they're there for. They'll write a quick sample on it. We did that. Oh, really? Yeah. Okay. And the reason I did it is because I grew up in more country, you know, we had well water. And so I remember my mom saying, you took your water to well, I didn't need to do that because we're in the city, but I didn't. Right. And it showed like how much fluoride. Okay. And then also question. You're not. Okay. It's just to give you a window of, you know, when you watch, just think about watching a YouTube video. How long is it? You know. You're not going to know. Okay. It's just that most people are going to have I mean, when you watch a video, sometimes it's go on as you show the help. And also with they have like target. Yeah, it just shows me that what you're doing is considered a so I don't have to put down like one thing. I don't really there's all the articles research they've done. Yeah, according to that, so you just put the objective and the target. Yep, just what healthy people think about your topic. Yep. All right, thank you very much. Same way. They're also doing advanced clean data, and it's also whatever they're trying to do as well. So anytime you have a pre-meter, you just set the age a little bit. They started putting in pictures and interviews people that have been babies now in their life. And their picture and then below it, they were using it. And one of the nurses that worked with me has her picture of her when she was little and now. It's just so good for parents to see that.
I asked her what all the rest of it she started by going with she did that conversation with my husband, but it's interesting thing that we don't know all that time. But she, I was going to ask my mom, so she was dancing. I didn't know about the house curious if it was, because I've been here I was here like 6 weeks.
You were on a suggested age, so they weren't expecting you to do a triple year. They kind of had a lot for you to do. Yeah, very good. It means a lot more, doesn't it, when it is not spiritual connection?
I laugh when you said the big head because we make fun of my brother. Yeah. And they had to shave his head so the idea that he had glasses so he looked like a little old man.
Oh, I know.
He especially had a really big head. And other bodies.
That's funny. I know it does. And people are like, are they from yes or something?
We did. We were like,
They've done a great job. All right, let's talk then about babies and solid food. So about 6 months, somewhere between about 4 to 6 months, supposed to come, we want to wait as close to 6 months as we can. Now some of you in the room are thinking, I couldn't wait. My baby started solid foods at 4 or 5 months. And those are individual situations, but usually closer to 6 months is when we try to introduce solid foods. Now that doesn't mean we just pull the breast milk and formula away from the baby. Probably harder on the mom at that point than the baby, but what we're trying to do is to give the baby another source for nutrition. The breast milk, the formula are great for hydration. They still help with nutrition, but we're trying to introduce another method for them to get food. But we don't want to just cold turkey and take them off of that. They still need that, if nothing else, for the attachment, the bonding, and all of that goes with that. We want to introduce solid foods gradually. There will be a lot of different rules for that. Some will tell you they want to start with the light foods. They want to start maybe with the meats or the vegetables first. A lot of doctors will say they want to do the fruits last because the fruits are sweet. Babies like fruits, so they know if they start with those, then they're just going to want those all the time, and they're not going to like some of the other things that are out there. So find out from the pediatricians how they want you to begin with that. Ask the parents to find out with that. But some of the general rules are we really try to introduce one food with 4 to 5 days in between. And the reason for that is just because we want to be able to watch for any allergies and food sensitivities. And it gives the baby time to kind of acquire a taste for that. So maybe we start with green beans, and then we go to a protein, and then we work up to peaches, you know. And they really like those peaches because they taste really good at that point. Also, respiratory distress, skin reactions, all of that are things that you want to make sure you look for. A lot of times parents say, well, I don't know, my baby likes to drink a lot. That doesn't sound good, but that's what they need. And so instead of an apple, I want to give them apple juice. Well, there's nothing wrong with apple juice, but it's just like us. They're more empty calories. So if a baby takes the apple juice, they may not like the apple as well. So you have to be really, really careful and monitor that. We also know if we drink too much fruit juice, that's also not good for our GI system. So sometimes babies can then become have diarrhea, and then parents are like, what's going on with that? So those are all things that we want to kind of watch and monitor how much they do. We just got done with this time of the year with all the things that are out there, the nuts and the candy. Obviously, I can't emphasize enough how important it is to inspect that. Kids are out in all kinds of little carnivals, fall festivals, whatever they've just been. I don't know how many times we've turned on, and found that there was a staple or there was a razor or whatever there was, a razor blade in candy, so it's important too as well. And then solid food again, you have to be really careful that they take small pieces. If they're going to have a Tootsie Roll, they can't have that whole Tootsie Roll because that's going to be something that could cause them to choke. Honey, you always want to beware with honey, and the reason for that is because honey produces the Clostridium bacteria, which can also cause infant botulism. Babies, because they have that clean gut, it takes them time to be able to digest. And so what happens a lot of times then is even up until the age of 2, they can still not have the mechanism to be able to digest food as well as when they get a little bit older. Now, solid food, we introduce that slowly. We give them food, baby food and those kinds of things that they can digest. As they get closer to 2, their clean gut has become more dirty, and now it can actually be able to digest things in a better way. But what happens is that honey just sits there and it basically ferments, and it produces the toxins that can cause the botulism for a child. So we really want to be very careful with honey. A lot of people think, well, if I go and I look for the best honey out there, that's going to be okay. We really avoid honey until children are 2 years and up. Food allergies and food intolerances or food insensitivities. And you're going to hear this from anything that people tell you. You're going to go in and see a name band, and it's going to have an allergy to Demerol. And you're going to ask Miss Smith what happens when she takes Demerol, and she's going to say, I get nauseous. Well, let me tell you, there's a lot of people out there that get nauseous to Demerol. We're not going to tell Miss Smith that, but we're going to think that. So what are we looking for when we're looking for allergies? Food allergies, drug allergies, whatever. Okay, we're looking for a systemic reaction, correct? So what's that going to present in itself? It's going to present as a rash. What else?
Swollen and can't breathe.
Okay, they might have the anaphylactic reaction, which is not the one we want, where they actually have trouble breathing. What else can happen? Could they have GI symptoms? What would they probably present like? Severe vomiting, diarrhea, they could have that just comes on all of a sudden. Okay, it's not that general feeling of malaise. And children, it's hard to assess that in sometimes. They just don't feel right, but you're really looking for a true reaction that's probably going to be more systemic in nature. And remember, those can happen anywhere from a couple hours to even a day and over. So sometimes they don't happen initially, and then we have to go back and look at a food recall to see what have they actually been taking. Now, food intolerance is different. Some of us have food intolerances, but we don't have a true allergy. Lactose is a good example of that. Some people, when they take lactose or they drink milk products, they have problems with that. Gluten, obviously. So there's a lot of different sensitivities that are out there. And so that many times involves us doing more food testing to see what those reactions are. Many times if we eliminate that food product or that substance, then the symptoms go away as well. So make sure that you get good history on them if they come in and say their child's having reactions towards something. How could you respond to the mom who says she puts her infant to bed each night with a bottle of Kool-Aid? You're not going to say what. You're going to keep your nurse face on, right? You're a horrible mother. Okay, so what are you going to say?
I wouldn't recommend that.
Okay, so what can you say first?
Why?
Positive. Is there anything positive with that situation? It's good that you're thinking of giving your baby something to drink before bed. All right? Very, very good. Okay, now you start with this other part of this, all right? Why is Kool-Aid not a good option? Empty calories, all right? It's going to fill them up and they're not going to want the good stuff that they need, right? Okay? And what else are you concerned about with, more important, putting her infant to bed with a bottle? We don't want the baby to choke. That's bottle propping, where we're actually going to have to keep the bottle in the mouth. It's going to cause the bacteria to accumulate on the gums and the oral cavity, and that's not going to be good. So those are the things you're going to teach her. So now she says, how should I feed the baby at night? What are you going to tell her? Not give them the Kool-Aid, but what? You could do water. You could do, if they're still doing a nighttime feeding of milk, breast, or formula feeding, that would be good. But to hold the baby and do it, and then put the baby in the bed. Make sure the baby has burped. Make sure the baby doesn't have a bottle in the bed when you do that, okay? So again, all those things, best intentions, but not always the best plan. All right, I posted with the lecture notes a growth grid for you to print off. Some of you didn't print it off, but you have it on an online version. So if you don't have it there with you, I want you to be able to look at it. So let me pull mine up so you can see it. It looks like this. When you're looking at a growth grid, it's really important to find two things: the age and the gender, all right? Now, if you have a fancy one, the boys are going to be blue and the girls are going to be pink, all right? Mine's not that way. This one's just going to look like black and white since it's scanned in. So when you're looking at that, you look at the top and it has birth to 36 months. So we do a growth grid like this till about 3 years, and then we start looking more at BMI in addition to watching their height and all of that. When you look at this, you're going to see that there's the birth age, which is what we do all the way up to 36 months. You also see that we have length, centimeters and inches, and we have weight, all right? Do not try to plot the length and the weight on the same grid, all right? You'll drive yourself nuts trying to do that, all right? There's a reason that you have two grids. So you have the length at the top and the weight at the bottom, all right? What that's going to give you is if you have a baby that, let's say they're 3 months, and let's say their length is maybe 25 inches, and you come over here and you look at that, that's going to give you a baby that's going to put you in an axis about somewhere about right there, all right? And that's going to tell you the percentile of the baby's height for the age it is, okay? What does that mean? If we plotted out 25 and 3 months, that would take us about right here. And if I follow that all the way over, that's going to give me 90th percentile on length. What does that mean?
I can't see your cursor on that.
I know, it's hard. I know. That's why I'm hoping you have a copy that you're looking at. So that's why I think a lot of times a hard copy is easier.
On mine, it looks like 25 is more 90, but 95%.
Yeah, closer to 90, between 90 and 95. But what does that mean? We're going to do an example later, and you're going to get a plan to plot it out, and then I'll show you a key, and it has it out there for you. What does that mean? If they tell you your baby is 90th percentile for his height.
They're longer than 90% of the babies their age.
Okay, so they're taller than what? Are they in the majority or minority? What do you think?
I think they're in the majority.
Okay, so if they're 90th percentile of all the babies out there that age, that gender, there's only 10% that are taller than they are. All right? So at that point, you're kind of thinking, my baby's going to be tall. Okay? So that's an isolated measurement, right? Okay, so now let's do that with weight. Let's say with weight, you get a baby that goes on this 50th percentile, which is right there in the middle. It's hard to see, but right there is that 50th percentile. Okay? What does that 50th percentile for weight mean? So let's start again. Of the babies out there that are this gender and this age, what does it mean? Because here's what's going to happen. The doctor's going to look at it and go, oh, your baby's doing great. He's 90th percentile in height and 15th percentile per weight. And you're going to be like, And then the doctor leaves, and then the nurse comes in, and they're like, what in the heck did that mean? All right? Hopefully the nurse practitioner explains it to them. All right? But if not, you're going to be the one that has to explain it to them. And I can't tell you how many moms have told me, I had no idea what that meant. I just went, Is that good? All right. So 50th percentile for weight. What does that mean? Anybody going to tell their child that mom or child is average? Please don't. Nobody ever has an average child, especially if it's your own. All right. So of the children out there, their child, only about half of them out there weigh more than they do. So they're kind of in the middle. And now it's the next question your mom's going to ask. Is that good? Does that mean he's gaining too much weight, enough weight? What do we know? It's one measurement. So at this point, we're going to start asking, what is he eating? How often are you feeding? What things are going on? You're going to get more of a lifestyle assessment, nutrition assessment. And then you can say, we'll continue to watch. This looks fine right now. We'll continue to watch and make sure that he or she is gaining the amount of weight they need. All right? And that's really what you're looking at. On the exam, too, you will not have to plot out one, but you will have to explain one. So make sure you know how to look at a case. I'll tell you what the percentile is, and you'll need to be able to explain that to a mom so you know how to do that, okay? All right, so that is a growth grid. Just some keys to help you with that. I've given you some steps that helps you make sure you've got the right one. Are you plotting it in the right section? It also talks to you about being able to put at the little percentile a little X. You can circle it to help you know where it is. And that's why a lot of times doing it in a hard copy is much easier than looking it on your computer. Okay? And we'll practice one yet today. So, all right, so that's a growth chart. We also do developmental screenings. Now, those are different than what we talked about. We've talked about looking at how the baby's growing, developing, and all that. The Denver Developmental Screening Tool, or the DDST-2, helps us to look at where is the baby developmentally, all right? It helps us to give us concerns. People like, places like Head Start, some of the follow-ups to kids at school or preschool, they're going to show us resources that help us with this. Most of the time, if we have babies that are high risk, maybe they're premature, maybe we're concerned about failure to thrive, maybe they're low birth weight, other concerns, we may go ahead and do this early on and then compare it as time goes on. So it's going to look at 4 areas. It's going to look at personal and social area, which really tells us how does that baby relate. Is it making the appropriate babbles? Is it doing nonverbal? It's kind of that expression we talked about, pre-verbal and all that. Fine motor skills. We don't expect a baby that's a year to be able to do, they're going to be able to do different things than a 3-year-old, a 3-month-old. But we want to make sure we start to look for that. Are they starting to grasp things at the appropriate level that they need to do that? We wouldn't want a 2-year-old to not have any pincer grasp. Language, again, how are they expressing themselves? Personal and social, a little different than language because we're looking at more nonverbal. Language, we're looking at how are they doing with expression and understanding and where are they at in that. And then gross motor, can they turn over? Can they start to sit up? What's appropriate for where they're at? So we do that anywhere from birth to 6 years old, and usually we do at least 2 assessments because we want to see if there's been improvement, if there's been continuation, all of that. Again, one measurement doesn't tell us there's a problem, but we want to look for that. The Denver Developmental Screening Test 2, you'll actually get more familiar with that when you go into your pediatrics in your senior 1 semester. But it gives you here, it'll tell you, like here you can see that there's P's and there's F's. I know it's hard on your notes. But what it tells you is pass or fail, or how did they do on that. And it'll tell you, like at 13 months, what should they be able to do and all of that. So those are all things that you would just circle when you talk or you assess them. Most of the time, if you are doing a baby and you have to have another observer to help you position the baby and do that, it's better to have it be someone that's going to be objective. So having the mom or the dad or the caregiver there is probably not going to be the best solution. Because we all know we're going to coax our kids to do what we want them to do, right? And so we want to make sure we have an objective measurement for this test. So it's better to have nurses or people that are trained to do this. Other things that we're going to do is we're also going to make sure that we offer the newborn screening test. There's about 16 tests the state of Texas requires us to test for. Things like galactosemia, PKU, looking for the phenylalanine, that enzyme that's missing, because those are really easy things that we can add a supplement and fix and help the baby to digest its food better and get the nutrients better. So those are things that are usually going to be done and offered in the hospital or right after the hospital clinic setting. We do an initial hearing screening on babies. That's a little bit newer. We haven't always done that. That helps to give us a baseline so that we can follow up if the test is abnormal. That's going to be really nice if we have kids that have lots of ear infections, recurrent ear infections. Maybe they have tubes put in until their eustachian tubes are able to drain the fluid a little bit better so they don't have all of the otitis media and all of that. And so we want to make sure that we follow up that all stays normal. Lead is something that we kind of think we're done with. We don't think much about lead exposure anymore. And one of the things that probably is the reason we do that is because we banned lead in paint many years ago. So when you buy paint today, you don't have the lead. When we go into homes today, if they're a newer home, we're pretty safe to say the wiring probably doesn't have lead, or if it does, it's very small amounts. So a lot of that's been taken care of. But the problem comes when we start using hand-me-downs, like maybe you have antique toys that are being passed down, or maybe there's been a crib in your family for years and the crib's up in the attic. Well, it hasn't been repainted, or maybe it has and the new paint has gotten off and scratched off, and so now you have the lead paint underneath. So those are all things that you need to be aware of as well. If you move into an older home, usually we say homes that were built before the 1960s, we're more concerned about greater amounts of lead. When we redo homes, those kinds of things. Christmas, we're getting to the point of the year where we have a lot of holiday wires, and we just get done with Halloween. A lot of the wiring that's made in other countries may still have some lead to it, and it tells you to wash your hands well and those kinds of things. You obviously don't want children putting those in their mouth, as they many times will do. So please know that lead is not gone. It's much better than it was, but again, people may not always be respectful of that, so make sure you educate them on that. One of the things I do want you to think about, though, is many times you'll have a child that comes in through the ER or wherever that situation is, and they are showing up with maybe some iron deficiency anemia. And you check through everything. You look at their diet, you look at their levels, you look at everything else that's going on, and all of a sudden you start thinking, you know, the one reason they could have iron deficiency anemia is because they've been exposed to lead. Well, one of the things we know happens is that lead and iron compete for one another, and usually lead wins. So lead actually robs the body of iron. So if you have a child that has a low iron level, think about lead exposure. It's okay if you need to rule it out, but it's better to think about it early on. And so that's one of those things, you know, no matter where you practice, if you never want to work with kids, you may still have one come in the ER or a parent that has a question about that. So remember that that's something that you always want to be conscious of. Immunizations, good news. I'm not going to expect you to memorize the whole American Academy of Pediatrics immunization schedule. As nurses, you will get to go back and look at those schedules and compare and make sure that the child that you're seeing is on the target as they should be. But one of the things I do want you to think about, though, is how to prepare parents for having immunizations for their child. Most of the time, that's more traumatic for the parents than the child, okay? And so it's really traumatic for parents to show up for a clinic visit and find out that their child's going to get a vaccine and they didn't know they were going to have to get a shot that day. So make sure that you look ahead if they're a clinic situation, and you can help them with that so they know that their child probably will get shots. And most of the time in that first year, they're getting a lot of shots when they come in for immunizations. There's also going to be a group of parents that's becoming wider and greater out there that may not want immunizations, and so they need to be aware of that. They need to discuss that with their provider so that they can make the best decision out there as well. So if they're going to have immunizations and you know they're going to do that, we want to make sure that they're prepared and the kid's prepared. So a lot of times we can have them either, some doctors will go ahead and prescribe the Emla cream, have them rub it on so it's not going to be quite as hurting for them and painful for them. They also might use a lidocaine cream, and then some providers are going to say, you know, it's going to take longer for that to take effect than for me to just give the baby a shot. We also want to make sure that the parents are going to be seen as the good people here, the nurses are the bad ones. And so we want to hold the baby if we have to when the baby gets a shot, and then give the baby right back to mom or dad or the support person, because we want the baby to see us as the bad person and mom and dad as the good person. Also, record keeping, really important. I don't think any of you got into this program without us looking at every information that you had on vaccines and immunizations. You were probably very thankful that your parents kept good records on you related to that. So all of that information, and it's getting harder and harder with needing lot numbers and all that. So if they can start that record keeping now, it's going to be really important. Most of the time we'll print that off in a clinic setting, but if they're not going to the same place all the time, that can be more problematic. And there's also a lot of electronic documentations, too, that they can use as well. So, and then I've given you, as we move into the holiday season, some of the recalls that are out there. It's a great website that will pull up some of the recalls, so hopefully you don't buy toys for your nieces and nephews that are on the recall list. And there's also some lead information, too, there, as well as some CDC information, too, on toys. So. All right, and again, just need to remind you that it is a nice way to start. Babies are a nice way to start people. Okay, let's do a couple checkpoint questions. Separation anxiety typically begins at what age? See, you're just going to breeze through exam 2. By 9 months of age, a pincer action is well developed, enabling the infant to A, increase locomotion, B, grasp small objects with thumb and forefinger, C, scoop up toys, or D, achieve increased depth perception? B? Awesome. All right. Questions on the infant? It's kind of the building blocks for all the other ages. So, okay. So then we get to the toddler age, and we all kind of smile when we get to the toddler age, because talk about a good training for that teenage years, and those toddler years. Between about 1 to 2 years of age is kind of when that falls. And really that's that autonomy versus shame and doubt developing. They had that trust versus mistrust, where we tried to kind of bring them the information they needed and kind of help them with that. But now we're really moving into that autonomy, where they're trying to become more independent. They want to do things on their own, and we need to kind of let them do that. But as parents, we know how time-consuming that is to let them to do that as well. They know how to act good, but they don't always make that choice, all right? And they're kind of in that walk and run phase. They were stationary for so long now that mobility is like their best friend. And so you try to get them dressed, and they run 100 different directions. You want them to sit down and eat, and they're like, why would I waste time sitting down and eating when I could be running? And so this is a very busy time for them. One thing that really stresses out parents during the toddler phase is that their growth rate slows. You know, babies have kind of been in that gaining weight. I mean, for them to triple their birth weight in a year, that's pretty big. So they've been eating a lot. I mean, they've been an eating machine. They are loving things. You give them all, and all of a sudden now they have something they like to do better, and that's run. And so they get to be active and on the go, and their growth rate kind of slows, and parents think, oh my gosh, I'm a horrible parent. My kid's not gaining weight as much as they were. That's what's normal. That's what they're supposed to do. They also have that cute little belly. There's only 2 times in your life you have a cute belly. When you're pregnant and when you're a toddler. That little protruding, it's just not as cute when it's a beer belly later on, right? And so they have that little protruding abdomen by about age 2. They start walking somewhere between about 12 to 15 months. Some may start as early as 10 months. Some may take even till 18 months. Again, you're looking for things that tell you that they're making an effort towards walking, not that they actually can walk. They start running as early as they can, and once they figure out that they can run, they're probably not going to do a lot of walking. But they're also going to fall a lot because they have those bowed legs, which is so cute with that little protruding abdomen. And when they walk, they kind of totter and do it. But they just pop down on their little butt, and they just pop right back up, and they get going again. Nothing's going to stop them. They also are getting a better pincer grasp, so even if you put like your keys on a high cabinet that they couldn't reach, they're getting to the point where they can now go, got it, and they can reach them. And so, I mean, every day it changes. They become more expressive, they understand things, but because they understand things, they practice their autonomy by their favorite word, which is no. They don't. They know now that they have some control. And so when you ask them, you've got to give them choices where no is not an option as well. Their vocabulary goes to about over 100 words. It may not all be words you understand. Parents many times understand them more than you, but they are able to communicate pretty well. And they should communicate. They should be making some efforts to communicate other than just pointing or doing expressions. They really do need routines, and they sometimes are learning the routines, and so because they now have a choice, they may say no for a little bit, but that's really important for them to be able to stay on a schedule. They're developing their social skills, they're trying to practice self-control, their attention span is getting a little bit better, and they know they're supposed to sit when you tell them to sit, but it's just not as much fun. And so they have to learn kind of how to balance that out. That separation anxiety is being replaced by trust. Many of you have probably dropped off loved ones or little ones' loved ones at a daycare center, and they were screaming when you left the door and you were in tears by the time you got to your car, only to find out at the end of the day that the caregiver or the daycare person said to you, oh, they only cried for a couple minutes after you left. You cried all day thinking about them crying for you, but they were fine. And so a lot of you have experienced that in one way or another. But at this point, they're starting to get more used to you returning. And sometimes they'll still exhibit a little separation anxiety, but it's more because they're sad that you're leaving, and they know when you leave, like when you go to clinic, well, you're going to be gone for a while, and they know that. But they also know that you're going to return. Milestones at this point, more the tricycle as they get closer to that age 3, jumping, they could stand on one foot and balance a little bit. They're starting to be able to put on their clothing, although they may not put on your choices. I had a good friend who I just loved. She'd had 2 children. That was her first virtue. And she learned on the second one that you kind of have to let them do their own thing. So her little girl would just come down, and she was just darling, but she would come down in like purple leggings and this really bright red something, and she would be like so excited. And you know, a lot of moms would have probably taken her and changed her so she matched, but her mom was like, she dressed herself, let her do it. And it was really important for her to do that, and to see the confidence in that little girl was good. So sometimes that's hard. They use a fork. They're starting to get to where they can use something other than a spoon. There's also sporks that are kind of a combination of the spoon and a fork. So something that's going to help them get that food to the mouth because they're getting better with those fine motor skills. And they like to build the tower blocks, but more importantly, they like to knock them down. How do toddlers play? Tell me about, you've got 2 toddlers who are getting together for a play date. Tell me what moms might expect, or dad. How are they going to play?
They don't like to share.
They don't like to share. I really don't like to share either, but... Pardon? Yeah, it's like parallel play is what it's called. Parallel play. And they play that way because they want to have the interaction of each other, but really their interaction is just being next to each other. So what happens is they get the kids together, maybe they have lunch and they play together, and as long as they're not wanting the same toy, the play date's great. All right? But if they start seeing something the other one wants, then they get that egocentric comes in and they want to take it from them. So as long as they both can play side by side, they're fine. They kind of imitate each other and have a good time. Everybody goes home and you're like, well, they didn't really even do anything. Well, that's what they're supposed to do. That's how you had a good, successful play date. They also want to keep busy imitating. I always said my son is never going to want to sweep, and I was so right now when I look at his room as a 16-year-old, that he was never going to want to do anything at home related to household chores, so I was going to let him do it when he was young, and I'm so glad I let him sweep the floor then. And they do. They want to do what they see you do. It may take them forever, but that's good. That keeps them busy doing those kinds of things as well. You know, bringing the laundry to the laundry room. I mean, you know, or whatever you need to do, or getting it in the hamper. That's going to take them at least a half an hour, and that's a good thing for you. That's going to keep them busy doing that. And they want to do repetition. They need to do things over and over again so that they can get better at it and they can learn. If you think about nutrition and where we learn to eat, you know, what do we think about? You know, it's Friday night, everybody's like, let's go out to dinner, I don't want to have to cook tonight, or this weekend, or maybe you guys think about that during the week when you're trying to study and doing all the things you are. Nutrition is a huge part of our life, and it's also a big part of our social life. And so these pictures just kind of show you all the things that we do for food. You know, we have parties centered around food, thank goodness, right? We're into holidays where we're starting to get into that whole thing where we have food everywhere, you know. And it's good food, and so nobody wants to miss out on that. But that's a part of it. We're just getting ready, many of us, to celebrate Thanksgiving, and that's going to be a time for family and a time for food and all of that. I know when we were at Disney World when Andrew was really young, we could have had breakfast with Mickey and lunch with Cinderella, and I'm sure Peter Pan was there for dinner, So there was all kinds of stuff that you can do, and it's all centered around food. So kids associate having a good time with eating. So I think that's why it's really important that we as adults help kids and help parents to understand that food is not a reward, although I know many times we use it as a reward, don't we? But that we want to foster that healthy relationship of it as well. And I think that's where a lot of us, getting back from talking about we can eat bad now because we're children, because when we're older, then we'll eat better. I even see that in my son. He was saying the other night, he goes, he had been to McDonald's a couple times and done something else with friends, and he says, I've just been eating all this fatty food. And I'm like, well, I'm just glad he's thinking of it that way. He'll probably still continue to do it, but I was just glad he was aware and mentioned that, because there's a lot of times where we just say, oh, that's just our norm, and I think we're getting away from that a little bit. But the other thing with nutrition and mealtime is what? There's the food, but what else? Yeah, and I bet a lot of you with your busy schedules are missing that right now because you don't always have that time, and there's not always time to make that sit-down meal. Even if it's a warm up something from the freezer, that's okay because it fosters that time together. And I think kids need to learn that mealtime is important too. We also know that kids are going to need much smaller portions than adults, and so I think we have to help parents to think about that. I'm going to give you some guidelines on that in a minute. And then also there's very common food allergies, peanuts, eggs, fish, a lot of those things now that we know are true allergies for kids, and we want to make sure that we're aware of that and know what happens if they intake those. ThePortionPlate.com, I've given you that website just to help you, which kind of looks more at kids and helping to modify that portion plate. We talked a lot about portions for adults early on in the semester. But until age 1, they're going to be getting some formula or breast milk as a supplement to their solid food. Okay, the first 6 months, that's going to be solely what they get. But then when they start getting solid food, I think it's really important that we don't just take that away. That needs to be something that the baby tells us when they're done with that, or maybe mom helps the baby to know when they're done with that. And there are some babies that breastfeed up until 2 to 3 years old, and some of you are like, oh, that sounds horrible. But we have to remember, in our culture, we may have different guidelines than other cultures. In some countries, babies, eat and feed breast milk until they're 3 and 4 and 5 years old. So our culture is not that. Our culture is more that they're done by about a year. But again, that's just a blanket guideline. From age 1 till about age 2, it's really important they have whole milk. Okay? Now some of you are thinking, I don't want my child to gain weight, I don't want them to have all that extra fat, but they need that extra fat because their brain really does a lot of that central nervous system development till about age 2. And so that's going to be really important that they still get that. Then at about age 2, if you want to start to work down, you can start to do like a 0.5%. Low-fat milk or whatever. I would not go to fat-free, but if you want your child to start to learn a little lesser fat milk so it tastes better, because it's sometimes harder to go from that creamy milk to that. So sometimes the earlier you do that, the better. But again, initially that first couple of years, it's really important they have as much fat as they can. And again, think about it. That's a good deal, right? We don't get it any other time in life, so don't take it away from them. I remember talking to a pediatrician once about feeding kids and how to know how much to feed kids, because I think parents just go berserk over how much their kids should or shouldn't eat. And he said, one of the things that helps you is if you think about the age of the child and spoonfuls of how much you're going to put on their plate. So 1 tablespoon per year of age. Now that doesn't mean you're going to give your child 1 tablespoon if they're a year of age, okay? I'm meaning for food groups. And so if you have a regular sized plate and you give your child 1 tablespoon of a protein, 1 vegetable, and 1 fruit, that's a pretty good portion. If they're 2 years old, you might want to go ahead and give them, 2 and see how they do with that. And one of the things the reason that I think that's helpful is because most of the time what we do is we give them too much, we inundate them, we overwhelm them, they look at it, they say, I can't do all this, I want to get out and run and do it, and they don't hardly eat anything, all right? And so I think we need to help children to not feel that. Now you and I, we go to Chili's and we order a margarita and we have chips Everybody's getting hungry now. And then we decide we're going to have lunch, right? And then we're going to decide, oh, but we really like that cookie thing, so we're going to divide that. And we're like miserable by the time we leave, but somehow we make it work, right? And remember, kids don't do that. They would rather be doing other stuff than eating, unlike adults. Adults think it's wonderful to sit down and eat a fun meal like that. And so you have to remember their priorities are different. So if we give them too much food, they're just going to put their hands up and take off because it just looks like too much to them. So those are just some general guidelines that may or may not help. Kids are going to let you know if they're hungry. I mean, that doesn't mean when they come back you're going to give them, the half a package of, Snickers bars that are left from Halloween. You have to help them understand they need to eat good food. And so sometimes then having them come back and eat what they were supposed to eat before is good. But I think a lot of times we just get so obsessed with food that we overwhelm them. And I think I asked you earlier on in the semester how many of you were Clean Plate Club users, and several of you raised your hand. Anybody remember having to sit there till they ate everything on their plate? Yeah. And so I think we've tried to get away from that and not give them so much so they don't feel like they have to do that as well. Kids need, in the toddler phase, about 1,300 calories per day. Their protein needs are going to increase to about 16 grams per day. Again, I'm not concerned about every number here, but I do want you to know that as toddlers, because they're moving, their muscle, they have more muscle development, they're going to need more calories, and so that's going to be important. And a lot of those calories need to come from protein. Elimination. So if parents aren't stressed about food for toddlers, they're stressed about whether they're pooping and peeing and if they're in the toilet and if they're still using pull-ups or whatever. And so I think it's really important that we remember that most of the time kids are going to toilet train when they're ready to toilet train. And again, it's another thing they're in charge of, which makes us feel real uncomfortable. Most of the time, girls may train a little bit earlier than boys. All right, you'll hear about some of these classes where you can potty train in a week, or maybe you're getting ready to have your second baby, and you're like, I just cannot have two in diapers, so I'm going to get this taken care of. Sometimes that works, sometimes that doesn't. But again, you have to have a child that's ready to do that, physically and emotionally ready to do that. Toilet training is a major stressor mostly for parents. And kids figure that out way on. They're like, this is good for me because I'm getting a lot of attention. And so, if I don't go to the bathroom in the right place, they're going to come find me. And that, sometimes bad reinforcement is okay, And so it's important that we help children to know where they should go and start working in that direction. Somewhere between about 18 to 36 months it should happen. This is another one of those things where parents and moms especially get all bent out of shape because Sarah was potty trained at 14 months and Johnny's still 36 months and he hasn't even thought about going to the bathroom, Kids are just going to determine that. There are things we can do to help them, to move them in that direction, but again, they're going to make that. And even when they do potty train, they're still going to have accidents because you know what? Going into the bathroom is not near as important as staying on that playground because they got to go get somebody and they got to let me in the door and they just don't have time for that. And so a lot of times that becomes an issue. And a lot of times we think that that means they're regressing and it's not. It's just part of that process. Toddlers need usually about 8 to 12 hours of sleep. They take less naps, but they still need naps. And they do know the routines. They know how to make those routines last longer because they know that I need to have my book read and I need to brush my teeth. And all of a sudden it starts taking longer and longer and longer. That's a lot of times because they know that they can prolong to have that happen. They may start to fear the dark. They're usually being exposed to more movies and things, electronics, as well as books and those kinds of things. So they've seen more, so they start to maybe fear the dark and have a few more bad dreams. Again, car seats, street safety, bike safety, because they're more mobile, their accidents, that is still going to be the #1 cause of injury for them, tends to be more things they're doing. They're learning to ride a trike, they're learning to cross the street, they're learning to run on the pavement, they're learning to jump off the swing, whatever it is as well. Burns, they're learning what the word hot means. They've seen mom work on the stove all the time and she doesn't seem like she gets hurt, or dad. So they think, well, I'm going to touch the stove, all right? Well, they put their hand on the burner instead of near the burner where mom did. And so then they learn, oh my gosh, that didn't work well. So there's a lot of that stuff. They see you work with candles. and all that kind of stuff too. So matches, you light the fireplace, whatever. So stove safety, making sure you have a fire safety plan, making sure that you have one that will work. Do the windows actually open if you plan to get the ladder down? So that's all important too. Do you have smoke detectors? Do they know what those mean if they hear that sound? And then also just making sure you talk to them about sun safety and keeping them protected too, especially here in Texas. Falls, sometimes the rail on the steps is much funner to come down the banister than to come down the steps, and so they're learning and experimenting as well, too. And then again, child-proofing the environment, because now they're not just on the ground, they're able to reach a lot of different things. Making sure you continue to think not just because they're older that they still couldn't choke, they could, because most of the time they're kind of eating on the go now, so making sure we cut up their food and all of that, making sure parents know the Heimlich maneuver, they know what to do with a child if they would start to choke, and then making sure that any chemicals, medicines, any of those kinds of things, even vitamins, are going to be out of their way, because most of the time, kids are going to see parents take a vitamin every day, so they think, well, they took one, maybe I can take all of them. And so they reach for the container that's on the center of the table, and they never had done that as well. All right, so the poison center, let's talk about that. Number that should be on every phone or somewhere that you can have it, or in your phone so you can dial it if you need to. And a lot of times I think people are afraid to access the poison center because they're afraid they're going to strictly call CPS or something right away. Well, I can tell you that there's a little HENIS screen up on the computer center, because my son has gotten into stuff and done stuff, and CPS hasn't knocked on my door yet, so I must look like I was an okay parent that just had an accident with my child. So make sure you get that word out that they need to do that. Now, the Poison Center is housed at Parkland. I'm not sure where it is in the new Parkland. I know it was in the basement at the old Parkland, but the number has stayed the same. But the Poison Center has lots of resources for you, all right? If you have a child that ingests something and you're concerned about it, or they took a leaf of a poinsettia and they bit the whole thing and there's nothing left of it, and you're like, I know poinsettias are poisonous or whatever, you can call them and they're going to give you the information you need, and they're going to tell you what you need to do. Why is that a better option than putting your child in the car and rushing over to the local ER? It's cheaper, okay, but probably at that point you're not thinking about that.
Well, something you can do at home is faster.
It's faster, okay? And what is the ER going to do when you come in with your child that ingested the poinsettia leaf? They're going to call the Poison Center, okay? And you're going to sit out there with whoever else until they determine what they need to do, all right? In that amount of time, you could already be talking to the Poison Center, and they could be helping you. A lot of the time, they're not going to have you do anything but watch, all right? If they need you to do something, if they need that child to be in the ER, they're going to let you know. The other part that's wonderful is they're going to be a resource for you, and they're going to follow up for you, okay? The ER may call you, they may not, but they're going to be there. They're going to call you in an hour, they're going to call you in 2 hours, they're going to call you the next day. They're going to make sure your child is okay and hasn't had any reaction from it. They're going to ask you things you don't even think, like, okay, so you say you put something in his mouth, how does his mouth look? What does it look around his lips? If they're concerned about a corrosive or anything like that. So they're going to ask you lots of good things. Do not think it's just limited to chemicals and medications. It's also limited to over-the-counter, all right? There's a reason that they put the child-proof medicines in a small container, all right? Have you ever wondered why you pay $10 for that little child-proof bottle that you're thinking, man, this is expensive? Most of the time, not always, but most of the time, they put an amount in that little teeny container that hopefully would not cause a fatal result. I'm not saying always, but most of the time they put smaller amounts in those, so if they were ingested, they could get better results with that. All right? And so that's why a lot of times they're smaller and than they should be. I mean, I've talked to people that their kids drank the whole Tylenol elixir, or they drank some of the cough syrup or whatever, and so they called Poison Center. And it wasn't that it was a poison, but it was they ingested too much, and so they said, or maybe they ingest like aspirin, or it's going to cause them to have a lot of sugar in them, and so they're going to run around the house for an hour, and then they're going to fall over because they're tired. But they're going to tell you all of that, so make sure you use that as a resource. Also, if you think your child's been exposed to lead, another good resource is the Poison Center. They're going to tell you what to watch for. They're going to tell you if you need to go to the ER to have them checked. They're going to tell you what you need to do. So that's really, really important. Plus, they have lots of good references. So I gave you the website address if you need it as well. Now, if you start calling every Friday night at 5 o'clock, and they start seeing every Friday at 5 o'clock Johnny has, some alcohol or whatever, they're probably going to be a little suspicious. But they're not just going to be suspicious just for normal life stuff. That's what they're there for. Other health promotion things, drowning. It seems like as our kids get older, it tends to be more of a concern for pools than it does for bathtubs. However, horrible story, had some students that were in my OB clinical and they were doing pediatrics. There was a time we did pediatrics and OB at the same time. Don't know what we were thinking, but we did. And so one week they were with me in OB and next week they were with at Cooks. And so they came and I could just tell everybody was just like, and I'm like, okay, what happened to all of you? And they're like, we had this horrible situation with tennis. So they told me about it. What had happened is they had an 18-month-old that was in the tub with his sister, and the sister was like 3, okay? The doorbell rang, all right? The doorbell rang. So Dad, Mom's not home, Dad goes to the front door to get the doorbell, all right? Ends up talking for a couple minutes, who knows how long it was. It was just long enough for that little 1.5-year-old to put its face down in the water. The 3-year-old's just in there playing, doesn't know that the little one needs to have his face up. And that little kid survived, but had no brain function left. And so here they are, my students, when that baby comes into Cooks, okay? Horrible story, even worse, Mom was a nurse. So Mom gets the phone call, and she's like, upset, and of course they saw the whole situation. Why did you leave, Life happens. How many times do we leave and we answer our cell phone and we're like, wrong number? Or, is there anybody more important than our kids and our family? No. So the doorbell, our phones, we just really need to keep conscious eye. Plus that little girl, how bad for her that her little brother had that happen to her when she was there and she really probably didn't know anything different, So tub bath. I tell parents that not to scare them. But I tell them, accidents happen every day, all right? And so you've just got to be aware. Giving them swimming lessons, helping them to be more conscious of the water, making sure if you have a pool in your facility, in your place that you live, or if in a facility where you're going to be at, that they have the proper, stuff that they can do, life jackets and that. Electrical shock. Electrical outlets are not for plug-ins. They're for fingers and paper clips and for pens for kids. So, and then it might even be more fun if it was wet, right? And so they have to trial and error. So child-proofing with plugs and doing all of that, making sure we teach them, we monitor them, are all going to be things we need to do. Animals. Animals look good, don't they? Even if they're a little tiny little dog, they can still bite. So making sure that we're supervising them, that we are conscious of strays and those kinds of things, because kids are not going to always have the best judgment on that. All right, so we are just around the corner from toy season, like it never ends, right? And you're going to be buying toys for I'm sure, people that you like. And you're going to go down the toy aisle, especially now, in Target, Walmart, and everywhere else you can go. And there are things out there that I don't even know where they came from. They're just like the coolest toys in the world. But if they are age inappropriate, they're the most common cause of injuries for toys, all right? So your little niece who's 6 months old, and you see this thing that's for someone that's 1.5 years old, and you're like, but my niece is brilliant. I already can tell that my niece is way ahead of the curve. And so I'm going to get her this little 1.5 year thing. The reason it's labeled 1.5 years is because developmentally, whether she's Einstein or not, all right, she's probably not ready for that toy, all right? And so it's really important that you remember that when you buy it. It's not that we think your loved one is dumb. It's that we know that developmentally, she's not going to be able to do this until she's 1.5 years or closer to that. So make sure you look at what does the toy say, what is the age, what are the parts, and what does it have to do with it. Also development, the finish of it, is it going to last? Is it something that she's going to take with her to daycare? If you're buying toys for daycare, obviously you want things that are wipeable and that they actually going to wash them off every day. And so making sure that all of those things are a part of that is going to make probably a very good mix. Stranger danger, we tell people every day not to talk to strangers, although we do it every day of our life. We go to the grocery store and we tell the person plastic or paper, we tell them debit or credit, we talk to people all the time. And we're actually nice to those people, but we don't know those people. So what do kids see? Kids see us talking to strangers. So then we tell them, you shouldn't talk to strangers. And they're like, what? You talk to strangers all the time, Mom. So then we have to help them understand that it needs to be people that we trust and it needs to be people that we help them with. It's really important that we always assess for abuse, potential abuse areas. That does not mean that we need to shake our fingers or make people think that we're suspicious of them. But if we start seeing children coming in with bruises, scars, wounds that aren't healing, if they seem to be neglected or anything like that, anytime a child tells us that they're being hurt or whatever, we need to listen to the child. And that's our professional obligation as a nurse. It is not our obligation to determine if anything has been done that the child needs to be rescued from. That's Child Protective Services. So if as a nurse you're working in those settings, you will have a form, you will have a process you go through to do that. But it's really important that we listen to the children and help them. And there's lots and lots of tracking, fingerprinting, lots of things we can do to help if children for some reason would be abducted and need to be located. Dental exams, hearing and vision screening, all things that we want to make sure we continue to assess for, and then obviously the ongoing immunizations depending upon what age and stuff they're at. Developmental testing, we talked about the Denver developmental, we talked about the growth grid, continuing to follow up on that, making sure that they're staying on track as well, and then also making sure that they have a caregiver, that they're socializing, that they're attaching, they're bonding, they're doing the things that we would expect them to do for their age. All right, let's take a break and let's come back in about 10 minutes, I guess, and then we'll yeah, let's do that. Yeah.
So awkward. I noticed the group's made, I guess, made a food matters discussion board, and I think everything would be kind of posted, like we're supposed to be posting that one.
Well, no. What they were supposed to do is post on the spot board, but we're going for
Because I posted an hour, but I guess I kind of been posting an hour. So.
yeah, no, you're fine. If you post it, as long as you post it on the board, then what you do is help you write your name. So as long as you post it.
She did an email saying you can put your name, but I put like, you mean like put your name like this?
Yeah.
Okay. And if I went to, if I had a responsibility to go to that this girl, and I still post it, even though it's not in the nobody would do it.
I'd rather you go back to your mom. So if you have,
I mean, I'll fix it. I mean,
yeah.
it's pretty. Okay.
He said he's already crashed.
Okay, so just post, I'll post my phone. But don't do the initial, just the response.
I would love to. Absolutely. You could ask for the sheet. Yes, okay. So we didn't wear it what? You know? Well, actually, most of the time I just hit play and it'll play on the show. I can scroll through here. Thank you. I know it's just hard for me to get up the steps. Are people stopping by?
Not necessarily on mine as much.
They're going to find food over there?
They're excited for the brownies.
We'll have to make sure they come find you too.
I have to do this not the first time.
You go find, you'll get, okay, I'll show you that. Well, I just, It should let you automatically at the end. Okay. Yeah. And then, did you insects, like when you write something, you do like, most of the people, what they're doing is like they do like a little paragraph with something in it underneath that they put it. I mean, if you have different sources, then you may have to, according to Smith or according to, you might have to do that a little bit. But what I don't want it to do is take away from your method, so it's cumbersome.
Okay, so we can do more like
Yeah. Yeah. That'd be fine. And then I know some presentations that most people do is they put at the end a reference to .com. Okay. For part of paying from retrieve from. Yep. Sounds like you're on the right track. No, I think you're on the right track. And then I know I just asked this question, but I had it for too much faces. I know, I don't know what happened. It's supposed to be in your private report. So I think what happened is people created a form before. That's where it's supposed to be. Okay, so for future microphones, and then it's a thread. Well, actually, the form is in a thread. Now, when you have to click on the zoom in, you click on the zoom in, you made that your forum, then your threads would be all over you. But what happened, a lot of people created numerous forums. Yeah, that's exactly what happened. So next semester, I'm just going to go through that because I haven't had that happen yet. And I guess people just didn't know how to do that. So that's fine. The GPA that's helping me rating, he has a spreadsheet, so he was tracking it. And he's found this really funny. Okay, and it's okay. And he's emailing if he can't find it. He's emailing if you ask him. Okay, and if we did do it, you can be fine. We have to reply. You're welcome. I'm going to correctly posted it in thread and put it underneath like it matters. We're finding it. Okay, so you want us to delete the one we posted? No. Or just leave it and then put a new one under that? Okay. Very good. Very good brownie, Sarah. So far, so good. Everything's just double the time. I think God teaches his patience in all kinds of ways.
I just, during this, like, during my time when we were kids, I had a good friend that I just remember that he looked at me, he just got a look on his face, and I had to go to the
Important it is for them to know that, and you need to tell their patients that story. Because you never think it's going to happen to you. You don't want to help them feeling what it does. Oh, I know. It's just at the point where I started to break the path.
Yeah.
We got to be that sick. And sometimes I
Yep, that was when it happened.
And sure enough,
And then they start eating fast.
see that look of distress as a your child.
Yeah, at least you knew what to do.
Yeah.
That's the big thing. Oh, you know, because like when kids go home from the dictionary, they have to know how to read the monitor. I mean, it takes them forever to learn all that.
Good story. Good outcome. All right. We're going to go through the preschooler, and then I want to take a couple minutes and let you go through and look at the growth grid so you know how to do that as well. And stuff, and then we'll see if we get through the school age. If not, we can always finish up next week. So. All right, so 2 to 6 years old is that preschooler, and boy, the preschool age is much different from the toddler because now they're able to follow rules more, they have more self-control, we're trying to get them ready for school, especially as they get closer to age 5 and 6. And the initiative versus guilt phase is kind of there with the tasks, and that's different from the autonomy in that now they realize their sense of purpose. They're trying to contribute, and so it's really important for them to be able to take the initiative to do things on their own. So they see you getting ready to go somewhere in the car, and they start bringing you stuff. And if you tell them, and you've seen them been devastated, I know I did it many times, I don't need all that. And they're like, they're crushed because they thought they were helping. And so, you know, obviously you're not going to give them a complex if you do that a few times. But what you're trying to do is help them to learn to contribute to society and to be purposeful and to do that on their own. And they're really role modeling. Growth and development, their abdominal muscles, they kind of lose that cute little, the protrusion they have, and now they have what we need, and that's an erect posture. Now they're not as cute anymore, but you can kind of see how they're growing up. They start to look more like a little boy or a little girl instead of that baby face, and that's always hard for parents. Their height and weight continues to have a steady increase, but it's not that real big incline, you know, because their height and weight is kind of leveled off. Their ears change in size and shape, which means if they've had recurrent ear infections, hopefully those are getting better for them. But it's really important you listen to how their language development is, especially if they've had recurrent ear infections, because that's going to play a role in how they've heard things and how they enunciate. So if everything has sounded really fuzzy as it's went in because there's been fluid in the ears and they've had that all the time, then how they enunciate words is going to change a little bit too. So it's really important to kind of watch that. By about age 2, they should have about 20 primary teeth, and then they should be starting more regular checkups because that's going to be important for their oral care as well. They definitely become much more aware of their sexual identity in their private areas, and their curiosity is really what takes over. They're not meaning it to be embarrassing, but, you know, they just really can't control when they are curious. And so you can be at Kroger in the middle of the store, in the middle of the aisle, and they're like, Mom, did you know I have a penis? And you're like, oh, my God. And everybody around you looks at you like you're the worst mom in the whole world. And at that point, you feel like you are. Or the little girl says, Mom, I found out today I have a vagina. Do you have one? And you're just like, oh, my gosh. You know, but they're really doing what we want them to do. I mean, you really want them to call their body parts by their right names. We're just happy they can say it. If you call the penis Peter or Fred, then they're going to say Peter or Fred, you know. That's just the way it is. But they're curious. That's really what's happening. But although we're embarrassed and we all look at, I just remember some parents looking at me and I'm like, really? Has no one else had children in this world but me? Because that's how you feel at that time. They're really just learning about their bodies. But what a wonderful, wonderful time. It's hard when you're in public. But when they're taking a bath or they're in the tub or you get them alone after that or whatever, is to talk to them about their bodies and make sure they understand that, their body is different than their brothers. And when they're in the tub, they may point and they may say, man, I don't have one of those, And they're kind of trying to figure it all out. But what a great time to tell them your bodies are different, to let them know no one should touch them in that area without mom or dad's permission. I always love when I see nurse practitioners and physicians that are working with kids on a day-to-day basis that talk to them and tell them, this is your private area and nobody should touch you down there without your permission. Nobody should hurt you there. This is what I'm going to do. I'm going to look. I'm going to see if everything looks okay, or you have an alley down there. Whatever it is, but that needs to really start. And there's no age that's too early for. So I think as nurses we can really help with them. But that's all it is curiosity. They're really not trying to embarrass you any more than a normal day is life of a parent, right? Play and activity, they're trying to separate from their parents. They really hate it that they still need you, but they do. And so although they're really an avid explorer, they're going to kind of run back to you for reassurance, and then they're on their way again. They may have imaginary friends. Anybody have imaginary friends? You notice how I didn't ask if anybody still had imaginary friends, okay? Next semester in mental health, if you still have an imaginary friend, you can figure out why that is, all right? But some kids do have imaginary friends, and they're invited to birthday parties, and they pull up a chair for them at the dinner table, and then I don't know if that worked for you, but some of you, all of a sudden, that imaginary friend is just gone. So, that happens, and that's healthy, that's okay. It's not something that we really need to make a big deal out of, but that's a part of, just a part of their developing, and that's normal unless it continues, and then that's an issue. They still like to help, and they want to model what they see you do, good or bad. They may pick up some of your habits that you don't like, but they also want to do things that you do and they see you do. Preschoolers play much differently than toddlers. They play more cooperatively, or they try to play cooperatively, so that means that they need to be engaged, interacting. They're not quite as egocentric because they want to do things with their peers. So many times when we enroll kids in interactive play, whether it's pumpkin patch or whether it's doing some tumbling thing or whatever, it's really not about the skill, it's about learning to work together. And team sports, at this age, even though they're fun to do and playing soccer is great, I remember my son, young, when he was starting to play soccer, he'd pick flowers during the game and run them over to me. And the dads just thought that was horrible, but really that's where he was at, okay? He was having a good time with the friends and learning how to share a little bit, but boy, those flowers looked really cute too. So, that's kind of where they're at. They're really not there to get soccer started yet. The toys you choose for a preschooler promote more of the cognitive reasoning and development, so they're learning numbers, colors, shapes, words, and that kind of stuff, and many of them are already doing that on their electronic devices early on. We do want to remember that they need active, healthy exercise, something other than sitting in front of the computer and watching people run 60 minutes a day. And again, they're learning that teamwork. That's really important at this point as well. They still need about 8 to 12 hours of sleep. Quiet time has now replaced naps. Naps are not popular at all. But they do need some downtime. More importantly, parents need downtime too. They need a little time to just decompress. They need to be away from their friends and just have a little chill time. And a lot of times that's still with technology, but the more you can get out of their hands, the better. Bedtime rituals become important. They now know that if I'm smart enough, I can prolong this whole routine. They've been working on that quite a while, and so a lot of times that becomes an issue too, because now they're smarter. Their night terrors, nightmares they can have. They can wake up, maybe it's from a dream, maybe it's from something they watched. But they know pretend and they know real. They're just trying to separate the two out. And they're kind of embarrassed if they think that they're scared. Preschoolers are many times eating away from adults, so they're really not at home as much, so you lose a little bit more control over what they eat and when they eat. They really don't like things mixed together. Now, they like to mix them together, But so if you're having them do cafeteria style or whatever, so a lot of times if you pick like a fruit and a vegetable and a protein or whatever it is, that will help a lot more than, you know, a casserole they're not always quite as excited about, although they love mac and cheese. Energy requirements go from about 1,300 to 1,800, so about 500 more calories they need at this age. Their protein goes up a little bit. Their fiber goes up a little bit too, which is important because a lot of kids can become constipated. And if that becomes an issue and continues, they can need bowel retraining for that. So you want to make sure they're getting good sources of the nutrients, including fiber, to help them. Elimination is hopefully getting much more independent, but they probably still need reminders. And they can have accidents, especially if they're doing something a lot more fun than having to take time to go to the bathroom. This is usually a popular age to start sleepovers, and so they can, if they do have any type of bedwetting, the enuresis, that becomes a problem for them because they may have that happen to them with their peers. Now when they're younger, school age, it's not as big a deal, but obviously as you get older, that becomes a huge deal. Encopresis, or many times they will leak stool. This happens a lot of times with kids that actually maybe don't have a bowel movement on a regular basis. Maybe they've been learning to hold it, or they've had constipation, and they're out playing and they don't go to the bathroom, and all of a sudden they've kind of taught their body to train their body to not have that bowel movement, and then when they need to have it, it really hurts, so they don't want to have it, so they have a bad experience with that. So sometimes that can be an issue too. So it's really important to watch them and make sure you know, even if they're doing independent toileting, that they're going to the bathroom. Health screening, we really want to just continue to build upon their history, look at their health practices, make sure they're doing all the preventative stuff from hearing, oral, and immunizations as well. And then also start to do more teaching for them. We've been doing a lot of teaching for the parents. We want to start working more with them. Their hearing and vision screening, usually they'll do a baseline before they start school by about 4 or 5, and then I know you've talked a little bit about, if you haven't yet, some of the screening for eye and vision, the Denver eye test, as well as the Snellen chart too. And then also encouraging them to still have their dental care, brushing their teeth, oral care. Some kids may already, as they start that early phase into school, already have braces on. Depends upon the orthodontist and stuff. So there may already be some oral care that's happening at that point. Testing then is really getting them ready for school, is looking at, are they ready for school in the way of going to a school, a public or private school? Do they need an extra year for school? Sometimes that will depend upon, you know, where their age falls. A lot of times boys need a little bit longer than girls developmentally. You know, intellectually they're usually ready. It's just academically, if they're going to be able to sit and do things, or are they going to be challenged or not challenged, and they're going to get bored. And so those are some of the things that we have to think about. So there are some school readiness testing that helps you. And then also just kind of researching and talking to people that have maybe worked with you, if you've been in a pre-K program with your child, whether they are ready actually to go to kindergarten. And there's not really a really good measure for that. That's going to depend a lot on your child and how you feel, and you know your child best. Safety awareness, motor vehicle accidents continue to be an issue. They are usually now getting closer to a booster seat, making sure they're restrained, making sure they know to use a seat belt, and then also checking as, you know, as a parent or adult. Bike and car seat safety, as they get a little older, those wearing those helmets are not as popular, and so they don't want to always do that, especially if their peers aren't wearing them. And then also they become much more adept at climbing furniture, you know, learning how to do stairs. They kind of know, but they still might need a little help. And then also they're at friends' house a lot, so, you know, gun safety, falls, knowing what to do in the case of a fire. Their drownings becomes more concerned about pools because they're more social and they're in more activities, and so they may be exposed to that as well. And then asthma, diabetes, you know, there are some cancers that are more characteristic for children if they have severe allergies. So all of those things can play a role in things that need to be monitored. All right, so let me, we're going to stop so that I can go through the growth grid with you and tell you a little bit about what is going on this week with case study. Before you do the Healthy Child case study that's due